patients.
Yes, again, Imad, I apologize.
You will, yeah, I know. That's why we put you first.
Yeah, so I'm sorry. I will have to leave after this, but I see you have some very good topics.
Yeah.
And some of my friends, Giovanni Brogi, I haven't seen him for a while.
Yeah, Giovanni is joining us today as well for the sitting position.
And Henry, of course.
You know Henry, and you know Dr. Uto from Japan, from Osaka. He is a very good endoscopic surgeon. Yeah.
Yes, I met him several times at some meetings. Very good, excellent surgeon. Yeah, he's going to also talk about CLIVAL tumors. I guess not just chordomas, other things.
Yeah. And our friend Jose will be coming from Brazil. We'll talk about his baby, about the foramen magnum meningioma.
Yes. Yeah, I talked to him a little while ago, and Brazil was having problems too with the politics and the COVID too.
Let's see who is following you so that he can check as well. Let's see. Second.
Should I minimize?
Is Dr. Takio with us? Dr. Takio Goto, are you with us?
I can't see him on the panelist list, Imad.
Hi, ma'am. Okay, let me see if I can get in touch with him. Japan is after us.
Hello,
is Giovanni with us?
Hello, James.
Giovanni?
He should be there.
Bantu? Sio? Bantu Sio, are you with us?
Not in the panelist list, Imad. Probably not logged in yet.
Yeah. Henry? They told me Giovanni is there. Perhaps he muted himself.
Hi.
Hi, Giovanni.
Everybody.
How are you? Good afternoon. How are you?
Giovanni, come stai?
Sto molto bene.
Tanto tempo che non ci vediamo.
Uccidiamo il virus.
Yes. Yes.
Hello, everyone.
Hi.
Hello, Vlad.
Vladimir, how are you?
Hello, Vladimir. Glad to see you.
Vlad, how are you?
Fred.
Yes. Nice to see you. How are you?
I'm fine. What about you?
Oh, we say we are hanging in there, trying to keep our head above the water.
Yeah, that is the same here.
Japanese guy Takio.
Just talking new restrictions, you know, and
Yes,
closing of everything.
Yes, we're having a second wave in Canada too, and you know, it's yesterday we had the highest number since April.
We have the same, that the numbers are increasing, and we now are talking that about closing the schools.
Again, I know, and the hospitals want to go back to phase 2 or phase 1. I don't know. It's crazy.
Phase whatever.
Yes.
Actually, it's increasing. As simple as that.
Right.
But the hospitals still cope with that, you know.
Yes, that's true. We are now about 80, almost 80-90% volume-wise what we were doing before.
Very high. Very high.
Still pretty high, but you know, we never know. Any day we could be put back.
You know, we have the problems with the ventilators. We have enough of them, but we do not have enough personnel.
Yes, exactly,
you know,
exactly.
You need 3 weeks, and they do not know in many hospitals how to manage 3 weeks. They are able to cope with a day or 2 ventilation, but not 3 weeks.
No, you're
That's a
absolutely
problem.
right. Because to us, you know what they said? Oh, you have a backlog, so you must now work 110%. And
Right.
you know, Saturday and Sunday. What they didn't realize that there's no nurses and there's no technicians, there's no, you know, anesthetists to work 110%. So you know, it's impossible.
Yeah, it's very similar everywhere probably.
Yeah.
And you have to get the patient coming. So
And then
some
you're right. Some patients will not come now. I
Will
had,
not
you know,
come, yeah.
they say, I don't want to go, older people in the hospital say, I don't want to come to the hospital. Anyways,
So in 3 minutes at my time, we will start, and they are trying to get hold. Dr. Takiyo with us now?
Yes.
Hello,
I can
Takeo.
join you.
Imad,
Nice to see you.
Igor, good to
Hi.
see you again.
hi, Takeo.
Good to see you. Hi, Vic.
Hi.
Takeo.
Hi, Vladimir.
Hi.
Hi, Imad.
Good to see you, all of you. Yeah, it was a busy program, Vladimir, as you know, today.
Yeah,
We're trying to
I
be
do.
on time. And I just give a summary about the course. It will be focused on, we said the midline tumor as just to embrace all the lectures in that subject. So in posterior fossa, starting from the front to the back. And then there will be 9 lecture, no quiz on this one. We'll try to trim the presentation between 15 to 20 minutes and 5 minutes for question and answer or discussion. It depends. If your lecture exceeds the 2 minutes, it's fine. Then we'll take it from your question. We will try to answer some of the question, but for the speakers, please look for the questions on the Q&A and on the chat and try to answer them if the time does not allow later on from the screen directly. People, they are very keen to have an answer to their questions. I'd like to welcome all the young trainees from around the world and from the 6 continents. Last 4th webinar, we exceed the number 1,000 because there were 6,000 or 7,000 registrants from China. We don't have a figure of their evaluation. It was very difficult, but we based the evaluation, I sent it to you, based on the responder. They were around 750 or 800. We have YouTube Live, we have TV, and we have the Zoom, of course. And the first session and the second day will be dedicated to spine and spinal tumor, will be moderated mainly by the Professor Vladimir Benish and the team. I think Salman is with him, somebody else. And we have invited speakers from outside the committee. We are welcoming them all. They have been great assets and great educators. And today the moderator will be with me, Igor Maldonado. He's Brazilian from Paris. And Professor Rames Carollo, Singapore. Both of them kindly accept to be moderators with me. And we hope we will be done by the 7-hour time. It means 4 hours of webinar. Without further ado, I'd like to present the first speakers, Professor Fred Gentili from Toronto, a major track record in skull-based surgery and endoscopic surgery. He has been a favorable guest to this committee, and he kindly accepted to give a presentation on CHORDOMA and endoscopy, the role of endoscopy and technique and possibly outcome. Fred?
So thank you very much, Imad. Can you see my screen, everyone?
Yes.
Yes, if you go into presentation mode.
Okay.
Very good.
Very good. So first of all, I have to thank you, Imad. I have to thank Vladimir for your kind invitation. I'm not a member of the Neuroanatomy committee, but I have to congratulate you. I think you've done an excellent job during this terrible time of pandemic for educational purposes. And I see already, you know, the number of participants here. So thank you very much. And I really appreciate participating. So my talk this morning, as you can see, is on chordomas, the role of endoscopic techniques. And I want to answer a question of whether have they really made any difference in patient outcomes. We always talk about endoscopic techniques, new techniques, and they're great, but we have to sort out, you know, are they really making a difference? Now, we know that these are very rare tumors, not that common. None of us see too many of these. They are centrally located, aggressive tumors that infiltrate the bone. And because of their proximity to critical neurovascular structures, there's a very high risk for postoperative morbidity. We all know that. And we know also that total resection is difficult, no question. And because of this, we know we have a high tendency of postoperative recurrence. And some will say up to 60%, 70%, 80%. And the interesting thing is, if you go into the literature, and find out, you see that there's no uniform consensus or guidelines for the optimal standard treatment for this aggressive tumor. Now, the management option for chordomas, like any tumor, of course, surgery, very radical surgery, attempts to try to get every little bit of the tumor, maximal, we call it maximal safe function and quality sparing surgery with radiation. And then some people have used radiation alone for this condition, medical therapy. Now we have the newer, you know, targeted molecular therapy. And then you see under observation, I've crossed that out. So my philosophy is, if I see a CLIVAL lesion, I will not watch this because it's so easy to get a biopsy transnasally, because if it's a chordoma, these are aggressive tumors and they must be treated. Now, the open approaches are many open approaches, anterior approaches, posterolateral approaches. And if you can see here, I've used all of these approaches for over my 30 years of experience for this tumor, because it is very difficult to get. So anterocentral approaches, anterocentral midface approaches, posterolateral approaches, anterolateral approaches, all of these approaches we have used. So I want to look at the first point of view. What are the results now of 25 years? I've been doing this for 25, 30 years, open skull-based surgery. We had the first unit in Canada back in the early 1980s. So what have we done about this? Well, this is a typical patient of mine. It shows you how long I've been in practice. 1995, this patient presented with a large chordoma that you can see here central. We, first of all, at that time, we were doing lateral rhinotomy. So we did a lateral rhinotomy for the central component. And then the year later, we did a far lateral suboccipital approach for the posterior component. He then went on to have proton beam therapy, which was the standard treatment at that time. So what happened? Well, 7 years later, he had a recurrence, and we did another lateral rhinotomy. Then 3 further recurrences, died 1 decade later in 10 years. And this is our series, our initial series of open approaches. You can see 96 patients. He was also included chondrosarcomas, but the chordomas, the progression-free survival was only 60%, with a mean follow-up of 8.4 years. If you look at the Harvard Leipzig proton beam group, they had, now they're even higher. You see that the chordoma actual control rates were only 64% at 5 years and only 4% at 10 years. But this doesn't even tell the whole story. To really find out about a condition, you got to look at population-based here, and the SEER bases do that. And so this is not just a series at high-end, situation in terms of hospital that have very expertise. This is all taking all together. You can see that the survival rates of these are 5 year 67%, 10 year 39%, and at 20 years only 13% of chordoma patients are alive. So what was my conclusion from this? My conclusion was that despite our current best efforts with the open approach in chordomas, the results remain, to me, very disappointing. That new strategies are needed for the treatment of chordomas, whether they be surgical, radiotherapy, or medical. And the question I want to answer today, if I can answer, is these 3 questions. Does the endoscopic approach offer advantages in the surgical treatment of chordomas? Can endoscopic techniques reduce complications and improve outcome and quality of life in chordomas? And finally, are we in fact dealing with tumor biology here, and that chordoma is not a surgically curable disease? Now, there's no question there's significant advantages to the endoscopic approach. Chordomas generally midline lesions if they go laterally, and this, of course, is a midline approach. It can access the entire skull base. There's no cranial nerve brain retraction, of course, there are disadvantages to all approaches, and of course, the restricted lateral access, and of course, the whole issue of reconstruction, which we've made significant progress. But as I said before, we have not totally solved this problem. Now, this is an anatomy seminar, so I thought I'd do a little bit of anatomy. And if you look at here, this is the endoscopic approaches for the different locations. Generally, they're midline approaches, I told you, but now because of the ability to do transpterygoid and a transcondylar, we can also go a little bit laterally. So these are some anatomy that one of my former colleagues, at least my fellows, John de Almeida, an excellent anatomist, did these beautiful anatomy. And this is basically the anatomy that you can see in the CLIVAL approach to the chordomas. Now, this is an interesting paper of one of my other former colleagues, Dolieto. Francesco is now in Rome, and he looked at the quantitative comparison of transnasal and transcranial approach for the clivus. And he did a computer-based analysis that he first learned from our, here, and then he continued in Brescia and now in London, looking at computer-based analysis of exposure and surgical volume. And you can see here basically that the endoscopic approach basically had a better option. And this was the results that he had. And you can all look at this, was just published in ACTA back in November. That the endoscopic transnasal approaches showed a higher working volume and larger exposure compared with the microsurgical transcranial approaches. So our series, as you see, not very many. These are, as we said, rare tumors over a number of decades. We have about now 50 patients. So this is a typical upper clival chordoma, very easy to get. This is like doing a pituitary tumor. This is extradural, and you can get a very nice radical removal. You can see here, there's no problem here with CSF leaks, as shown here, but we also use a nasal septal flap here because the patient's gonna have radiation. And so this patient, you can see 4 days, no CSF leak, proton beam therapy, 8 years with no evidence of disease recurrence. Now this is a mid-clival chordoma, and this is intradural. People, I think that chordomas are all extradural, but at least a third or sometimes even more have intradural extension. I don't have time to show the movie here, but you can see this patient here and had a CSF leak. He needed a lumbar drain, length of stay 8 days, then proton beam, 14 years with stable disease. This is also a lower clival chordoma. So the endoscopic approach does allow us to go quite low, really almost down basically to the condo, and we can get some, at least removal of this chordoma in the lower clivus. So this patient, as you can see, 2 days in hospital. This patient then had IMRT. We have switched over from proton beam. No longer do we do proton beam. We give IMRT photon radiation. Our radiation specialists have done now, and we published this, it's in the literature, that at least short term, that the IMRT photon, it has equal results as proton beam. And they don't have to go to Boston. This is now 7 years, no disease recurrence. I just want to show this patient, 44-year-old female with this very, very aggressive, large chordoma going into the brainstem. As you can see, there's a clivus that's not totally pneumatized, you can see here. So what is the best approach here? There's no question in my mind, there's no other approach but the endoscopic approach. And this is to show, because this clivus was there, we had to do a full clivectomy that you can see here. And this is very more difficult when it's not pneumatized. You have to be careful about the periclival carotids. We use image guidance, Doppler ultrasound or whatever. Here's where it went through. You can see where the chordoma went into the interdural into the brainstem. And again, I'm just going to very quickly, because of time, this is us taking it out, use very typical microsurgical technique, the way you would do under a microscope. And here we are after the removal, very difficult, but in the end, we got a very nice radical removal, perimedian vessels that you can see here. Now, we don't have to fool ourselves that we got a total removal here, but we got a nice radical removal. And this patient, as you can see, 6 hours, no neurological deficit, had improvement in her sixth nerve palsy, lengths of stay only 5 days, and then she had IMRT. She's 6 years with stable disease. Now, there are limits to the endoscopic transcrival approach, the significant lateral or posterolateral extension of the tumors, significant inferior to the body of C2, and of course, you have to have experience. So this is a young lady that presented at 20 years old, had this tumor, presented with progressive hemiparesis on the right side from this chordoma. What is the best approach here? Well, we're no longer doing versus, open versus. They're complementary. And here's one that I did a combined staged open and endoscopic. The first stage was an open subtemporal approach that we did into the brainstem that allowed us to get a nice removal of this cone. And then the second stage was an endonasal endoscopic approach, very easy to get. And this patient now is 14 years. She had adjuvant IMRT 14 years, and she is stable. So this is our results of our initial series, 2008, 12 years ago. It's 19 patients. You can see the symptoms, the usual symptoms of cranial nerve palsy, sick nerve palsy. A third of them had prior treatment with surgery radiation. And the results were about 70%. I say here gross total removal, but you know, that's a really misnomer. I cannot say that I had gross total. There's always some residual disease as far as I'm concerned. All patients had radiation. The average follow-up, as you see here, however, very, very short. The clinical outcomes, however, were very satisfying. Sixth nerve palsy, complete recovery, lower cranial nerve palsy improved. We never saw this in the open approaches. The cranial nerve issues were always a problem. The hemiparesis improved. Progression-free survival only was 94%, but again, we have to be careful about the average follow-up. And the CSF leaks rates were very high initially, 26% with a nasoseptal flap. Now we're less than 10%. This is an interesting one that, again, one of my fellows are doing a long-term follow-up. And in chordomas, whether craniopharyngiomas, wherever they are, meningiomas, you have to follow the patient to get a real idea. So if we look at these patients, 37 patients, you see the similar kind of symptoms. But if you look at the results, the gross hormone rate, true total gross hormone was only 21%. And you can see, again, the complication were very good, very few, at least low complication. But the progression or recurrence, the ones were 49%, almost 50%. If you follow these patients, the follow-up was 37 months plus or minus 28 months. And then if you go in the literature, you see that, and you have to, there's always comparison in the literature, open versus endoscopic. And we have to understand, we have to be very careful in these because often they're comparing apples and oranges. So this study, as you can see here, looking at 37 studies, but you see there's twice as many open series as endoscopic series. If you look at the follow-up, 3 times almost the follow-up in the open than the endoscopic. However, the gross total removal rates were higher in the endoscopic approach, as you can see here, and the post-op complications significantly higher in the open approaches and cranial nerve deficits higher. And the CSF leak rates here were about similar. So now we have the first international consensus statement on endoscopic surgery. And we looked at, I was asked to do one on meningiomas. This is one is on CLIVAL chordomas. The problem is that, you cannot, and what they do is basically do the redneck thing. They go to looking at the level of evidence, that is A, B, C, D, down in terms of randomized studies, all the way down to retrospective studies, to opinion, and then they give a recommendation, level of recommendation. The problem is, it's very difficult to compare precisely open and endoscopic approach. And nevertheless, their benefits, they concluded that the endoscopic approach to clivus offers an opportunity for increased extent of removal and decreased surgical morbidity, and that they recommended that the endoscopic approach was the best approach for midline lesions. So, can we answer these questions? Does the endoscopic approach offer advantages in the surgical treatment of chordomas? My answer, I think, is yes. Can the endoscopic approach reduce complication and improve outcome in chordomas? I think the answer is yes. Are we dealing with tumor biology that chordoma is not truly a surgically cured disease? And here, I think yes, but some people would say no. So in conclusion, have endoscopic techniques? I think yes. While the series are small, short follow-up, and the level of evidence is still low, I think the endoscopic approach has proven to be a very viable alternative to transcranial procedures and the approach of choice in the majority of chordomas. With proper patient selection, the more direct and less invasive nature make the endoscopic approach the preferred technique and equivalent or better with better extensive resection rates than the standard open microsurgical approaches with significantly less morbidity, mortality, and improved quality of life. However, there are limitations to the endoscopic approach, and combined stage open endoscopic approaches may be required in some patients, especially those with lower clival lesion and significant lateral extension. And a well-trained skull-based surgeon needs to be familiar with both endoscopic and transcranial approaches. Now, while surgery remains the mainstay of treatment for chordoma, I think that total removal still remains very difficult, regardless of what approach you use. And while postoperative radiation therapy is generally recommended in chordoma, we see no significant advantages identified of any delivery technique, whether it be proton, MRT, photon, or carbon. And while the analysis of larger series of patients' longer follow-up are needed to fully validate it, I think there's no question that the current state of the art is endoscopic approaches, and it will become the standard of care in the management of most craniopharyngiomas. Now, in conclusion, I believe that it's unlikely that surgery alone will ever be the ultimate solution for chordomas. And we have to look at other things. What do we have? Well, with radiation, we said these are really radiation-resistant tumors. And then medical therapy, what about target therapy? And this is, some people would say this is the next step in the treatment of chordoma is molecular targeted therapy. And I just want to end with my patient. This is a doctor that came to me back in 2007, 13 years ago, with this CLIVAL chordoma that he had. What is the best approach? Well, we did a combined approach. Initially, we did a retrosigmoid approach to deal with the posterior component. And then basically we did a staged transclival endoscopic approach. And this patient then had proton beam therapy. 6 years, he was with no evidence of disease. What happened in 2014? New 12th nerve palsy with the residual recurrence, at least in the posterior fossa. He had a repeat posterior fossa craniotomy, post-operative residual. What do you do now with this further recurrence? He had a post-fossa, I should say, craniotomy repeat to 16, further recurrence, repeat surgery. What do you do? 16, repeat post-fossa craniotomy. Now another surgery. What now? Observe, repeat radiation. In 2017, he was put on afitinib, is a tyrosine kinase inhibitor. This was based on genetic testing of his tumor. He's now 3 years with stable disease and radiologically stable. We can only keep our fingers crossed because, you know, that this patient will have another recurrence. So the management, evaluation of a patient with chordoma, I think are best served by treatment in a high volume specialized center that utilizes a multidisciplinary team approach with the active participation of many subspecialty neurosurgeons, ENT surgeon, radiation oncologists, medical oncologists, radiotherapists, and endocrinology. So surgery, chemotherapy, thank you very much for your attention.
Well, thank you very much, Fred, for this comprehensive review of the topics and with the results about endoscopy and the outcome. Very impressive, and I hope in the future we'll have additional information about the target therapy and other modality. We have a chance to get one questions for the subject from the panels.
Can I, Imad?
Yeah, go ahead, Brad.
Fred, do you drill the bone as much as possible?
Yes, Vladimir, I think in these you try to do the most possible. And when I say, you know, rare, that's the problem when in terms of getting a total removal, because these infiltrate the bone. And if you have a nice central clival chordoma that you can get around, we will do that. But as soon as you go to lateral, you get the sixth nerve is there. And, you know, we do not want to, you know, damage the sixth nerve when we know we're not going to get a total removal. But we try as much as possible. I mean, we're as aggressive as we can, but we have this concept of safe, function sparing, quality of life sparing surgery for these.
Thank you.
Imad, can I ask a related question?
Of course, yeah. Sanjeeva from Oxford Group.
Fred, thank you very much for an excellent talk, and I agree fully with that. We use a combined open and endoscopic approach for our chordomas. But I have a question in the contained chordomas, and you said it's hard to get a complete resection, and I agree. But if it's extradural, would you resect the dura to get a margin, which we do not do, but some centers, I believe, like Pittsburgh and stuff, do that?
Yeah.
What is and
I
stamp and
think,
things like that?
I think again, Sanjeeva, it relates to whether I think by resecting that dura, I can get clear margins. You know, if I think there's a possibility, yes, I will do that. But then do you send margins? You know, I do many operations with my ENT colleagues. And of course, you know, cancer surgery, there's margins. And we don't do that in neurosurgery. You know, if
That's
you really
right.
want to do that, we should do it. Take a little margin in there. And my feeling is I will look at that. And if I think that there's microscopic disease going, you know, lateral, then there's no use taking the dura where you're going to then get a big CSF leak and then you're not going to get a margin.
Thank you.
May I ask one question? What is your view when you are faced with a recurrent case for surgery and the oncologist says there is no option of further radiotherapy or radiation treatment?
Yes, that's where, Ramez, we go on to targeted therapy. Yeah, I don't have time here about the target therapy. You know, I think it's something that's coming, but there's no real hard data, no real hard series that have shown, you know, really documented. But when we have nothing else, we go to our medical oncologist and then they do molecular profiling of the tumor. That's very important. These are specific targeted therapy. And if they can find a target in their tumor, we will then do a targeted molecular therapy like we did with this last patient.
And you avoid surgery. You will avoid surgery in this case.
Well, I mean, no. I should say if surgery is physically possible, of course we will do it. You saw that patient I did, he had 4 surgeries. But at the end, you get to the situation where there's surgery impossible, then, you know, we go targeted therapy. No, if surgery is technically feasible, it's not going to ruin the patient, we will still do surgery. But there comes a time where surgery is no longer has a role to play. That's where then we will go to targeted therapy.
Thank you.
All right, Fedwa, thank you very much. I know you have to catch up with your operating room.
Yeah. Well, listen, I want to thank everyone, and particularly say Vladimir and you for the great, amazing work you're doing with the committee. And I look forward to another talk, your next session. Bye-bye, everyone. Thank you.
Bye-bye. Take care.
Bye.
Now, I'd like, in the same token, I'd like to invite Professor Takio Goto. He is from Osaka, a professor and chairman of the Department of Neuroscience and Neurosurgery. I am happy to say that Osaka has developed a track record from the time Hakuba and then, of course, Professor Ohata, and now Professor Takio Goto, an astute endoscopic surgeon, skull-based surgeon. He's going to talk again about the merits of endoscopy approach to CLIVAL tumors. So, Professor Takio, please. If you can share the screen for your presentation, you are already on.
Yes, I feel very honored to have the opportunity to share my work with you. So today, I will talk about the merit of endoscopic endonasal approach to CLIVAL tumor and the challenges. When we planned the surgical resection of the CLIVAL tumor by the endoscopic endonasal approach, I always remember this anatomical image, especially focus on the location of the carotid artery and the sixth nerve. So in my idea, the anatomical location between the tumor and the carotid artery and the sixth nerve is very important to decide the surgical plan. For example, in case of the pure petroclival meningioma, in such case, attachment of the tumor is partially behind the carotid artery and also behind the sixth nerve. So even use the endoscopic endonasal approach, this is an endoscopic view around the petroclival junction. But in case of the pure petroclival meningioma, sixth nerve running ventral side of the tumor. So surgical resection of the endoscopic endonasal approach usually not easy. In addition, when we access through the nose to the petroclival junction, we have to completely drill out the posterior clinoid process and also remove the posterior petroclinoid ligament. This ligament usually very fibrous and hard, and in some case, this is a calcified ligament. I will show the typical case. This is the petroclival meningioma. This patient referred to us with increasing tumor during the follow-up, but she was 26, very young girl, so we decided the surgical resection. But the region located to the left side. And so at first I tried the combined anterior transpetrosal approach, but the problem is that Sylvian vein is well developed and drained to the middle fossa. So if we choose the anterior petrosal approach, we have some risk to damage this venous system. So I decided to remove the tumor by the endoscopic endonasal approach. But this patient has a large posterior clinoid process and also posterior petroral ligament calcified. So we have to remove this calcified tumor. I will show our surgical video. When we access the petroclival junction, at first we have to widely drill out the bony structure. This is the upper clivus, and this is the lateral end of the clivus. This is a paraclival carotid artery. When we try the total clivectomy, we have to expose the paraclival carotid artery. And then, this case, posterior clinoid process was very large. In such situation, we have to dissect and elevate the dura mater upward to expose the posterior clinoid, and then drill out. This is a posterior clinoid. We carefully dissect the tip of the clinoid and then remove. And this is a paraclival carotid artery. When we try to drill out the petroclival junction, we have to mobilize the carotid artery to lateral side and drill out the bony structure. And then we start the coagulation of the dura mater and cut the attachment of the tumor. This is the medial side of the attachment. I carefully cut and start to remove the tumor from medial to lateral side. Usually, the Q-cell was very effective to perform the internal decompression. But the lateral side tumor was very tough and fibrous. So using the endoscopic endonasal approach, to remove the tumor around the lateral side was very difficult. This is a sixth nerve, and I continue the internal decompression and carefully dissect the tumor from the sixth nerve. But as now I present, the attachment of the tumor is partially behind the sixth nerve. So to remove this part was very difficult. And this is a posterior petroclinoid hold. This part was calcified, so we have to remove this calcified part. After remove the hard calcification, we can go to the more deepest side. This is the sixth nerve. I carefully dissect the tumor sixth nerve and go to the deepest part. This case, finally, we could resect almost all tumor. But in my impression, surgical removal was not easy, very difficult. After that, we shield the dura mater and cover the large mucosal flap. Fortunately, this case, we can remove the most part of the tumor and preserve the sixth nerve. I remove out the posterior clinoid and calcified posterior petroclinoid ligament to go to the deep side. On the other hand, if the tumor is CLIVAL and lower petroclival meningioma, attachment of the tumor is a ventral side of sixth nerve or below the sixth nerve. In such situation, if we access the TRANSCLIVAL approach, we can directly access the attachment of the tumor. So endoscopic endonasal approach was very effective. This is a surgical video. At first, I widely drilled out the clivus and exposed the paraclival carotid artery on both sides. This wide bone work was very effective to completely devascularize and detach the attachment of the tumor. In case of the pure clivus meningioma, devascularization and detachment was relatively safe compared with petroclival meningioma. So sixth nerve is here. So we can gently dissect the tumor. This is a vertebral artery. I carefully dissect the tumor of the sixth nerve and then also to start to dissect from the ICA. This is the ICA. I carefully dissect. And this is a lower cranial nerve. Tumor is completely medial side of the lower cranial nerve. So using this approach, we can carefully reach the medial side of the cranial nerves. This is a pontomedullary junction, and this is a facial nerve. Tumor severely compress the brainstem around the pontomedullary junction, but endoscopic endonasal approach can offer the direct view, and finally, all tumor was resected out, and cranial nerve completely preserved. Brainstem was successfully decompressed, and the tumor also completely removed out with preservation of the neurological function. This is another case of posterior clinoid meningioma. In this case, attachment of the tumor is posterior clinoid and upper clivus. In such situation, attachment is here, so attachment is completely medial side of the sixth nerve and also medial side of the carotid artery. In such situation, endoscopic endonasal approach very effective. This is a cella floor, and this is the inferior wall of the cavernous sinus, and this is a paraclival carotid artery. This is a pituitary gland. I dissect the pituitary gland from the medial wall of cavernous sinus and completely expose the posterior clinoid process. This is a posterior clinoid process, and I drill out this bony structure. This dramata is the attachment of the tumor. So after remove the posterior clinoid process, we can directly expose the attachment, I mean the origin of the tumor. So I gently mobilize the carotid artery to lateral side and enlarge the surgical corridor. This is a pituitary gland, and this is a carotid artery. And I coagulate and detach the tumor. I carefully dissect the tumor of the surrounding structure. And this is a optic chiasma, and this is a pituitary stalk. I dissected the tumor piece by piece, and finally the tumor was resected out. I resect the tumor piece by piece, and now then all tumor was resected out. Exposure of the carotid artery very important to mobilize the carotid artery to lateral side. This is a oculomotor, this is a PCA and a PCOM, pituitary stalk gland. So the tumor was completely removed out. But when we operated the TRANSCLIVAL approach, we have to watertightly seal the dural defect. In such situation, I think the dural suturing technique is very important to perform the watertightly dural closure. Of course, watertight closure was very difficult, but to put some stitch was very important to put the tension to duramata. I repeated the same procedure several times, and duramata was almost watertightly sealed, and then covers a large mucosal flap. After that, dural defect completely sealed. So tumor was resected out, and patient symptom improved. This is another case of the recurrent epidermoid. The main location of the tumor is the ventral side of the brainstem. And in sagittal image, tumor compresses the pons from below to above. In such situation, location of the tumor is a pure ventral side of the brainstem. In such situation, also, TRANSCLIVAL approach very effective. This is a paraclival artery. When we try the total clivectomy, exposure of the carotid artery on both sides is very important and a good landmark to know the lateral margin of the clivus. And then we start to remove the tumor. This is the tumor migraine to the brainstem. But endoscopic endonasal approach can offer the very good surgical view to confirm the border of the tumor and the brainstem. This is a mammillary body, and this is an oculomotor nerve. So now we can reach the upper end of the tumor. And this is the lower end of the tumor. This is a basilar artery, and this is a vertebral artery. We carefully remove the tumor. This is a sixth nerve. So medial side of the sixth nerve, this procedure very effective. I carefully remove the whole capsule carefully. And this is the facial and vestibular nerve. And this is a pons, and this is the lateral surface of the pons. After resection of the tumor, we can reach the lateral part of the pons and remove out the tumor. Now the most capsule and the tumor was resected out, and the brainstem completely decompressed. After that, we made the large dural defect. So we have to watertightly seal the dural defect around the clivus. In our surgical experience, to seal the duramata around the clivus was very important to prevent the CSF leakage. So I sutured the duramata several stitches. This needle holder was very effective to perform the suture deepest side. I carefully suture the duramata and put the tension to duramata like this. After that, we insert the fat tissue to subdural space to prevent the CSF leakage. After finish this procedure, dural defect almost watertightly sealed. So this suturing technique was very effective to prevent the CSF leakage. Now we confirm the almost dural defect watertightly sealed like this, and then cover the large mucosal flap like this. So postoperatively, most part of the tumor was resected out and the dural defect completely sealed. So when we plan the surgical procedure to the CLIVAL region, I think anatomical relation between the abducens nerve and the origin of the tumor is a key issue to estimate the effectiveness of the endoscopic endonasal approach. In case of the petroclival meningioma, attachment of the tumor partially behind the carotid artery and also behind the sixth nerve. So surgical removal is not easy. On the other hand, the CLIVAL tumor located ventral or medial side of the abducens nerve. Endoscopic procedure will be very, very effective. So when considered the surgical approach to the CLIVAL tumor, in case of the petroclival meningioma, I prefer to use the transcranial approach, but tumors located ventral or medial side of the sixth nerve, I choose the endoscopic endonasal approach. So if all you have is a hammer, everything looks like nail. So we should master both surgical approach, endoscopic endonasal and transcranial skull-base approach to remove the clivus tumor. Thank you for attention.
Thank you, Professor Takio, for this nice presentation and embracing the new innovation of endoscopy to tackle this lesion from a different approach. I open the podium for 1 or 2 short questions from the panelists.
May I ask?
Ramesh?
Yeah, that was a wonderful talk. Actually, I'm very impressed by the surgical technique you're using, Professor Goto. I just want to ask a technical question about the debulking of the tumor. I saw you using the ultrasonic aspirator. Do you use any other instrument like debrider, microdebrider, which some seem to be effective in such tumors?
In Japan, we cannot use the microdebrider in the transnasal approach. So I prefer to use the QSER. Endoscopic, the use QSER is very effective.
Thank you.
The white tube you have in the video, is it an ultrasound or what was it? Or it's just for irrigation?
Doppler, I suspect.
It's a Doppler, yeah?
Sorry, then our internet system is not good, so I cannot catch what you say. So
yeah, during the video there was a white tube.
Give me question again.
Yeah, the white tube you have in the video, is it the Doppler?
Sorry,
is it the Doppler ultrasounds?
Doppler.
Doppler. Yeah. Of course, when we confirm the location of the carotid artery, I use the Doppler. But paraclival area, carotid artery covers the dura mater, so there's meticulous drilling enough to prevent the injury of the carotid artery.
One day from the panelists said this might be the suction tube, possibly, I don't know. It looks like a very simple tube. Okay. If no question, we'll move to the next speaker. I'm pleased to ask.
I would have one comment.
Please, go ahead.
Yeah, this is a course for young people. And what I would like to point out that both speakers, both Takeo and Fred, mentioned and stressed the sixth nerve. Sixth nerve is a very important structure, and the loss of the function of the abducens is virtually a loss of an eye. And this should be, let's say, well kept by the trainees and by young people, that the sixth nerve is not unimportant structure, that it's really important structure which should be preserved at all costs.
Very valid point, yeah.
Yes. I completely agree. with the
Takashi.
opinion of Benny.
Yeah, Professor Takashi has a question.
Yeah, I have. I'm Dr. Kon from Showa University, Tokyo, Japan. Thank you for a very interesting, very informative speech. As you had a very good technique of a wide area of endoscopic approach, and what do you think is the upper limit, your upper limit of doing endoscopic surgery? Because we have sometimes do the combined approach. What do you think, in your opinion, what the indication of combined approach, the upper limit of the endoscopic approach?
In case of the endoscopic approach, we can reach the upper side. So if the tumor extends upward, I choose the just endonasal approach. But endoscopic approach has a lateral limitation. When the tumor extends to the lateral side, in some cases, I choose the combined approach, transcranial and endoscopic approach.
Okay, thank you. Thank you.
Thank you. For the attendees, the complexity of the presentation is a wide range. Some of them, they are very sophisticated, like the one just presented. And because we cater for all range of trainees and practicing neurosurgeons. So you will find some lectures is beyond the level, and some of the lecture is at the level. So just bear with us, and because this is the value for everyone. I'll move for the next presentation if there is no question or comment from the panel. The next presentation will be by Professor Giovanni Greggi. I'm pleased to ask him with vast experience, and he's going to give us an insight about the sitting position, advantages and limitations.
Oh, thank you. I tried to share my my video. I'm sorry, I got the. Do you see my video?
Not yet.
Not yet.
Now?
No.
No, I think if you step out and you recheck in.
Okay. No. Okay, I step out and I try to check in again. Zoom, it's okay.
Yeah, we can see it. Can see your screen.
We see your screen. If you go for your presentation.
I go to my presentation and now has to. Okay, did you see it?
Yes.
Okay.
You are on.
Okay, thank you. So till now we went from the front of the skull and now we are going to the back of the skull. I try not to steal too much the podium to Imad that he will talk later on about.
No, you can give it all, I know that.
Okay, I have nothing to disclose. The pineal region tumor are very important for this kind of approach. We go very fast, not to, as I said, steal the podium to Imad, but that is the percentage of the tumors. Mainly are germ cell tumors, but you can have also other type of tumors as well. The advantage of this approach is that for the median line lesion, you can go supracerebral, subtemporal, transitorial, interhemispheric, and anterovera for the 4 ventricles, and we have also the lateral approach that you can do in the sitting position, and you see here the images, and you can make also combined approach if you need it. This is the interhemispheric transsensorial retrospinal approach is not my favorite approach, That was some slide that shown by Charlie Teo that was doing that with the endoscope, and you see that you can easily reach the critical structure in this situation, that is the basal vein of Rosenthal and the bridging vein, occipital bridging vein. And the picture are fantastic. Of course, as was said before, for the endoscopic approach to the CLIVALs, you have to be, there is a learning curve that is quite important in this situation, because any kind of bleeding will be a kind of disaster for the patient and for your heart. So supracerebellar infratentorial is that my favorite, and that's as you I will show what is our experience, and just to only one short video to just to show you what is the advantage of the sitting position. No retractor, a wide corridor, and you can work quite easily in this with this approach. Let's go, and that's for the epidermoid is the same things. You see that again, no retraction. I mean, retractorless is the gravity that is making the retraction, and you can work quite easily with the different instruments. But our goal is the pineal approach and the sitting position. It's quite good for young people, and that was a case of pilocytic astrocytoma. And this is pre and post. It can be done also endoscopically, but for question of time, I shift this video. And the telovelar, again, is an approach that's quite easy for the lesion that's sitting into the ventricles or on the floor of the ventricles, and you have a huge approach when you get into the sitting position. For this approach, the sitting position is viable. I will say this mandatory. The possible complication of the sitting position is embolism, of gas embolism, direct or paradox, the hypoperfusion, the pneumocephalus, and the compression of peripheral nerves, and that is slowing down the use of this in the neurosurgery. This is the sitting position. It can be also semi-sitting. That means that the knees and the heart is quite at the level of the head, because you are tilting the operating table. There was a review and a letter to editor in the 2002, 20 years ago, on the British Journal of Anesthesia, and said which specific differential sets can be denied, and the conclusion was should be limit the use of sitting position or not, and our experience say no. The advantage is, as I say, gravitary draining of the blood and CSF, the optimal approach to midline lesions, wide working corridor without retraction because of the gravity, and the bleeding of the venous capillary bleeding is really reduced a lot. In the best, it was never abandoned, and that is the 178 case in 1 year. This is our experience, and of course that is due to the good relation with the anesthesiologist, and the team of the anesthesiologists were quite very important. And this was the complication in the year 2010. Complication in 150 consecutive cases in 1 year, 2010, That's what the complication. And you see here what to do when you get a detection of, I'm sorry, I go back. One by one, we go through this all this complication and how you can take care of that. The iron atrium, the anesthesiologist should be in the operating room and tell you immediately what is going on. And the things is to cover the field with gauze and to search the entrance that usually is muscle or skin. So, and you can close it with the bipolar, with Surgicel, with the Magic Staff, that is the flow seal or Surgiflow, that the hemostatic agent with fibrin. And the anesthetist should say, I take out the gas from the heart, and that's the problem is over. What are the pneumocephalus? There is a predisposition and mechanism is the advanced age because of some atrophy, some too large anti-edema of drugs done intraoperatively immediately, and the length of surgery is quite important. The result is a so-called inverted papal button. But this pneumocephalus is present also if you put the patient in the prone or concorde position or supine position, almost in 30% of the surgery. So, for instance, that was a surgery for epilepsy, and you see that is this huge pneumocephalus. That was an acute MCA aneurysm with hematoma, and again, you get this situation. In pediatric patient, you have to be, the resolution of the pneumocephalus can be slow. It will take days, but it will take care. The control should be, patient should be intubated, remain intubated for a while, so that the patient should go to the intensive care without too extubated. And when after the control of CT, the pneumocephalus is reduced, you can extubate the patient and do the oxygen therapy, and the head should be in this situation. And the only thing is that you have to wait. No be in a hurry. Don't try to overcome this situation and awake the patient before the time. This is some cases. Can you see here the huge metastasis and second postoperative days in spite of the pneumocephalus is on seat, is standing, and this is another case. Pulmonary embolism, complication and physiological consequence. Doppler cardiac false positive is the embolism was detected in 36%, 40% intra-arterial air, reduction of the CO in 32%, never reduction of the PO2. And that is the experience of other group, Ernest Niemi in particular, and did a lot of paper on that. About also in the far lateral sitting position can be helpful, but I'm not going into this detail. Preoperative selection of the patient. It's mandatory to have a transcranial Doppler with microbubble injection to avoid that there was a atrium opening, congenital or not close during the life. Transesophageal echodoppler and an assessment of the cerebral atrophy that you can see in the MRI, and of course cardiovascular assessment. Monitoring is mandatory again. Evoked potential, the BIS to check the situation of the cortical activity, and the transcranial Doppler, and that is very, very important. The central venous catheter that allow the anesthesiologist to take out the air embolism. In conclusion, the advantage, as you say before, the gravity drainage of the bloody material and CSF during the surgery, very wide corridor to approach the midline lesion, no retraction or very limited retraction because the help of the gravity, less venous and capillary bleeding, and a reduction of intracranial pressure. Limit. Need of an expert anesthesiological team for this approach. Fatigue for the surgeon, we will discuss in the next slide. Need of surgical anatomical training, because the anatomy is not the one that we can find in the cadaveric specimen. It's moving because of the gravity. And you have to understand what are the venous drainage, the importance of that, and be trained on this situation very at easy during the surgery. Patient selection, we said, and pre-op examination is very important. Intraoperative monitoring is quite important again because of the position and because of the traction that can be done also in the long pathway of the spinal cord. But pro and con. Sami almost did all the surgery in sitting and semi-sitting position. Spetzler refused that because he was saying that it was too tiring for his shoulder. And that is a question also of attitude of the surgeon. And if you won't do that, you have to be trained to work with the very high situation for your arm, and you have a way to place your hand just to be not fatigued when the surgery is very long. This is the acknowledgement to all my group, the best group. This is the anesthesiology we're working with, and this is the Maria Hospital team that helped me in this presentation. Thank you.
Thank you very much, Punji, for this presentation. I can see the last one was not in sitting position on the boat. It was oblique.
This is concordant position.
So he was not in fatigue, this guy. Okay, so we have chance to get one or two comments or questions. I think I have a statement here, Dr. Ibrahim Subeh with us. Sitting position is here to stay, we all agree. It's one of the approaches. Of course, you tailor it according what you need. But for me, pineal region is the real indication for this case. And semi-sitting position, perhaps even it protect you from many of the other complications. But there are limitations and advantages, which I'm going to cover that you did not cover, Giovanni, because you left something for me. Wonderful. We have a chance to get some comment or questions. Any questions? There is some publication, pediatric in general, they don't like sitting position in general. But I remember Professor Lapra, and you know him very well from France. He has one of the largest series of the pineal region, and he did most of them in semi-sitting position. The other thing you mentioned in one of the slides of tetraplegia. And this is a risk when people start doing sitting position for myelopathy, doing laminectomy on the posterior cervical spine in elderly. This is because of the age, they have that complication. I think if you do it in the age of the pineal region age, which are the younger group, you don't have this complication as real. I just want to give this comment.
About that, we can make a comment that I forgot in the presentation. When you place the patient in the sitting position, the patient should not be under courier. That means that you have to have a tonic situation because the anesthesiologist can help you in warning when you stretch too much the neck. That is quite important.
That's very important. Yeah. All right, we'll move to the next topics. Is Professor Wang Tu Xiu with us?
Yes, I'm here.
Nice
Thank
to
you.
have you here with us.
Yeah, thank you very much for
accepting the invitation.
inviting me.
He is the head of neurosurgery in Singapore, and he is going to give a presentation on approaches to pediatric midline posterior fossa tumor. This subject has been very well asked about from the attendees to cover some pediatric, and I'm happy to have you with us to cover this subject and share your expertise. Please go ahead.
Thank you so much. So I'm going to talk on the surgical approaches to the pediatric midline posterior fossa tumors. And basically, when we look at the distribution of brain tumors in children, you'll find that actually about half of them are in the posterior fossa. Although not all of them are in the midline, but a large majority of them are. And when you look at the common posterior fossa tumors in children, we talk about the medulloblastomas, ependymomas, pilocystic astrocytomas, of course, even the brainstem gliomas, they're all in the midline. And so from a surgical approach perspective, the anatomical location is more important than histology, right? And so you need the imaging studies like the MRIs to help us to provide a 3D perspective to the location, and that is crucial in preoperative assessment. So for instance, you can see this is a midline posterior fossa tumor, turned out to be a medulloblastoma. This was also a huge, big medulloblastoma. And again, you know, the size also and where the actual location of tumor is affects how you approach the tumor. Sorry, go back. This is another medulloblastoma, but you can see this is a nodular lesion, right? So again, a different type of medulloblastoma. Now, of course, with the subclassification, subtyping, you know, again, you still need to remove most of these tumors anyway. And then you can see a ependymoma, and they can be, again, in the midline, although some of them will extend through the lateral recess into the CP angle. And of course, many of these tumors will also come out through the foramen regione into the upper cervical spine area, right? And you can see this looks very ugly looking, but this is actually a benign tumor, turned out to be a pilocystic astrocytoma. Of course, some of these tumors are even the medulloblastoma, they can be more in the hemisphere, as you can see here. And then you can also get a low-grade pilocytic astrocytoma, which actually includes in the whole site of the one whole hemisphere, right? And the question is, in cases like this, do you approach from a midline or do you need to go from the side and so forth? And then they're even more lateral than midline, as you can see in some of this. Again, this turned out to also to be a medulloblastoma. So radiology itself does not tell you what the histology is, right? And I remember clearly Christian Senrose, you know, who was one of my mentors. He always say, radiology is not pathology. So there are tumors that are more lateral than midline, like the pilocytic astrocytoma. You can see one of these, right? Because it tends to go much more to the side as well. And then you might have also infiltrative pontine glioma. Obviously, this is a midline glioma, although a tumor, although most of us will not consider doing surgery, although we are starting to do more stereotactic biopsy in some of these cases. And then you have a focal pontine exophytic glioma, and these are surgical cases that you will need to do. And then there are also a group of tumors called the cervical medullary gliomas. They are not only just in the midline, but also like the ependymomas, they go all the way down and involve the upper part of the spinal cord. And this was the case that we operated on the midline, and it turned out to be a pilomyxoid astrocytoma. And then, of course, you do get once in a while a lesion like a hemangioblastoma here. And then there are also other types of tumors like the atypical teratoid rhabdoid tumor that are basically in the midline, although they are not exactly in the fourth ventricle. And again, this one will probably need a supracerebellar approach, which is not what we'll be discussing here today. So obviously, their preoperative considerations are important. So when we present a lesion post fossa, you need to understand the pathology, involved structure. You obviously need to have preoperative imaging. Usually MRI is a very important modality to have so that you can look for proximity to cranial nerve, surgical accessibility, vascular involvement, and of course the presence of hydrocephalus. And if there's hydrocephalus, you will need to address that before you go for surgery, either a ventriculostomy or a shunt although in our unit, we don't shunt these patients anymore. Of course, if you suspect that might be a hemangioblastoma or other vascular lesion, you might want to consider preoperative angiography. Now, so management of associated hydrocephalus, right? Ventriculostomy is usually placed, and for us, it's either in the frontal or occipital region, right? This depends on the surgeon, and it's either before or at the beginning of surgery. So like if the hydrocephalus is very severe and the patient looks very sick, we might put in a frontal external ventricular catheter before proceeding the day before, and then plan for surgery the next day, right? Actually, in 90% of our patients, the obstructive hydrocephalus is expected to be reversible, and most of the time, it is reversible. And so we now hardly put in shunts for patients with posterior fossa tumor. Once you have removed the tumor, the obstructive hydrocephalus is relieved. And of course, at the time of surgery, CSF diversion is usually helpful in relaxing the cerebellum, although there are actually pediatric neurosurgeons who do not believe in draining the CSF because they feel that once the tumor is out, the hydrocephalus will be settled. Right? So we do not form ETBs or ventriculoperitoneal shunt. But if a shunt had been inserted in another institution and the patient comes to us for the surgery, we tend to leave the shunt alone unless there are complications arising from the shunt. So because this is a neuroanatomy webinar to some extent, I think I have to talk a little bit about the surgical anatomy. So basically, when we operate on these tumors, we're coming in from the posterior surface of the cerebellum, which is located obviously below the transverse sinus and between the sigmoid sinuses. And the vermis is the part that we would be operating into or around. It's folded into and forms the suboccipital cortical surface with the posterior incisura, right? Which is the deep vertical depression on the posterior surface of the cerebellum. Right? And the vermian surface is the part in superior part is the pyramid, and the inferior part is the uvula. And then the median margin of the rostral part borders the tapering line. So you have the tonsils here. Right? And then this incisura is continuous with the vacuola, right, which is the cleft that opens between the tonsils into the foramen of Magendie. Now the superior foreventricular roof, you can see here, actually the roof is a tent-shaped thing, you see on the sagittal cuts, and the apex of that is the fastigium. And then this divides the roof into two parts, the superior medullary velum on the superiorly and the inferior medullary velum inferiorly, right? And the superior half will therefore formed by superior medullary velum, which connects the fastigium, and then also with these inner surfaces of the superior and inferior cerebellar peduncles. And actually, when you're taking out a foreventricular tumor, you are actually many ways dissecting the tumor laterally from the inner surfaces of the superior and inferior cerebellar peduncles. And then the fibers of the superior cerebellar peduncle arises from the dentate nucleus. And this is important because later on when we talk about cerebellar mutism, we believe that some of these structures, dentate nucleus and the tracts that go along the superior cerebellar peduncle are probably involved in the causation. Inferiorly, the inferior foreventricular roof, okay, which is formed by the inferior medullary velum and then the tilia choroidea, which overlies the lower part of the floor. And the velum is that inferior medullary velum is membranous remnant of connection between the nodule and the flocculus that forms the old part of the vein. So you can see this is the tila here, right, and the inferior medullary velum. All right, and then caudally it attaches to the tela choroidea, and then it contains a vascular layer of choroidal arteries and veins. So these are very small ones between its layers. So this is a nice picture taken from Matushio's book, where you see that half of the cerebellum is removed, and you can see the diagram of the tila, the superior cerebral peduncle, inferior cerebral peduncle surfaces very nicely, and then of course the floor, right? And this is what he calls the cerebellum medullary fissure. This is a sagittal view, which is long here. Okay. And looking at the lovellar anatomy, so the telovellar junction, and you can see clearly here, is a line attachment of the inferior medullary velum to the tilia choroidea, and it extends laterally from the nodule into the lateral recess. Right, the tilia attaches the inferior edges of the floor, along the tinea, and which meets at the opex, right? So right here. Okay, and then there are openings from the tilia choroidea into the subnet recess, the foramen Luschka, and also the foramen of Lejeune. He mentioned about the cerebellomedullary fissure, right, which you can see here, and laterally you can see here. So this extends superior between the cerebellum and the medulla oblongata, and their ventral dorsal walls. The ventral wall is formed by the posterior surface of the medulla, inferior medullary velum, tilia choroidea, dorsal wall by the uvula, tonsils, and the biventral lobules. So this feature extends superiorly to the level of the lateral recess, superior to the level of the lateral recess, which is here, and all the way up to the foramen Monroe, right? And then it communicates with the cerebellopontine fissure through the foramen Luschka. I think a very important structure is the posterior inferior cerebellar artery, the pica. It arises from the vertebral artery at the interior margin of the medulla oblongata, and then it actually causes through a series of fissures. There are 5 segments: the anterior medullary, lateral medullary, tonsillar medullary, tonsillar, and cortical segment. And the part that's most commonly exposed, as you can see in this diagram here, is actually the tonsillar segment, right, which actually occurs in the cleft that lies between the tonsils and the tilia choroidea, right? And from there, it actually bifurcates the medial and lateral trunks. And importantly, it supplies the vermis, and the lateral trunk supplies most of the hemispherical and tonsillar surface. And then they are frequently encountered during approaches to fourth ventricle, but many times actually they usually do not get in the way. And then finally, looking at the floor and the lateral recesses, right? This is the rhomboid figure, and we know it very well. And basically, many tumors do not arise from the floor except the pontine gliomas, and occasionally some of the ependymoma are stuck to the floor. Otherwise, most of the time, they tend to be free, although you could get bits of tumor that's actually stuck to the floor, right? So the apex will go up into the aqueduct, and then the lower part at the obex, which actually goes into the foramen of Lejeune. And then laterally, they go into the foramen Luschka at the lateral recess. So the standard approach surgically is actually to do a suboccipital craniotomy. And this is really the mainstay. Most of us will do a suboccipital craniotomy for midline lesions. Now, for our group, we tend to operate with the patients in the prone position. Although I must say that when I was training in Australia, my boss, every posterior fossa tumor, right, whether it's a medulloblastoma, astrocytoma, was actually done in the prone position. And that's because they had a very enthusiastic anesthetic team. I think frequently you will find units that don't use the sitting position regularly. That's because the anesthetists are not very comfortable using that. We tend to use, for posterior fossa surgery, I tend to use the Suvita head holder because I like the way how the retractors actually I find are very, very good for retraction, right? And of course, the head is flexed and translated posteriorly to allow for visualization pathology. And just going to be careful that you, especially in children, right, rather than adults, flexion may not be easy, but in children, actually, it's very easy to flex the head. And there's a need to make sure that you do not block the jugular outflow, or more importantly, many times you can actually kink the endotracheal tube. Now, of course, you need to put paddings and so forth, and we tilt the head a little bit up. Now, I like the prone position also because, right, this is the usual position of the microscope, but sometimes when you want to look at the lesion, if it extends higher, you just go behind the patient and almost like in a Concord position, although in a Concord position, we tend to have the patient much more elevated, but in the prone position, you can still come from the back and look up, especially when the lesion has gone supracerebellar. So obviously you need to make sure that the lower part, the upper part of the body is free of any shields, anything like that will block your way. And then the incision is quite standard and it's usually placed just below the transverse sinuses, okay? Now in pediatrics, I don't tend to remove C1, and we just do a craniotomy involving the lower part. And what we do is actually we do a, usually just enough to get to the place, and if the lesion is not very high, I don't even go up to the level of the transverse sinus. But obviously, if the lesion extend quite high up, then you need to make sure that you expose the sinus to make sure that you can go up into the supracerebellar space. Right? So we tend to use a craniotome to do a craniotomy. Right? We'll put a couple of burr holes here, and then using the foot plate, we actually, and a bit of dissection, we will actually get a foot plate in, and then you can actually turn the thing. Otherwise, you just get to because of the keel here in the upper part, sometimes you may not be able to do a full craniotomy, which case then we'll just use the drill to drill it down. And I'll show you. So this is the posterior fossa craniotomy. You can see that we can actually use the craniotome to do, and it goes all the way up to the burr hole on each side. All right. Then basically from there, you can actually just drill up the thing, and then the whole piece of bone can come out in a piece. And we will usually replace the bone at the end of the surgery as well. Right? So we don't leave the dura fixed. Sorry, we don't leave we put the bone back. Okay. And then, so we do not routinely remove posterior arch of C1, but sometimes, especially for ependymomas and obviously the cervical medullary tumors, when this tumor extends below the level of C1, as you can visualize on the MRI, then we may actually remove C1. The dura opening is standard, usually a Y-shaped manner, and these are the situations where you got to really, children especially, and very, very young infants, sometimes there are huge, big veins and even pools of dura in the dura pools, venous pools in the dura. So dura opening, you got to be careful. This is more or less the standard way where you open and then you use clips, or else sometimes I even just use the bipolar and I burn the vessels to allow me to get to the to open up the dura. Okay, and this is sort of picture that you can see at the time of surgery. Okay, now, so okay, obviously the point for discussion is what is the approach, what's the best approach to the fourth ventricle, and basically we are usually faced with two: the transverment approach where you make a section through the vermis, or the talovellar approach where you dissect out the ileum tinea here and then go in, and we'll discuss this as we go along. So basically, this is the traditional approach, and this is the approach that I was taught more than almost 30 years ago when I started doing neurosurgery. And basically, it involves splitting the inferior vermis, right, from the pyramid down, and expose the nodule and underlying talovellar surface, and the incisions carried through, and then you split to visualize the entire four. And if you do the split, you can actually get to about 4 cm from the opex to the Sylvan aqueduct, right? But it's limited by its exposure to the lateral recess. So in fact, what you do is you incise the inferior vermis, you retract the two halves. So this is what people call vermis splitting. Now you limit the incision to the smallest possible length to gain access. So I start usually with not too much, and then if I need to, then I will extend the incision upwards, right? And you go up to as far as the vestigium, so you don't touch, you try to avoid the superior medullary vellum. I think that's important to really reduce, I believe, cerebral mutism. Then inferiorly, you take it down to the underlying nodule, and then you also open up the tiliacoridea. Actually, if you open up tiliacoridea widely, you can actually get to the lateral recess. So it's not too different from the talovellar approach in some ways, right? And it gives you up to 2 centimeters of working space. And then when you add in the inferior part, you actually get the 4 cm that I spoke of. Now, the talovellar approach is different, okay? This is, I say, basically what you do is you remove the tiliacoridea and then part of the inferior medullary vellum, and then you mobilize the tonsils, you free them up with extensive sharp arachnoidal lysis. Then you will see, and then you need to preserve the tonsil lobes of the pica. And then you with careful dissection from tela to the level of foramen majondi to the velum, you allow visualization of the entire fourth ventricle, right? And if you do, and what it says is that if you do the additional dissection out, so it means you can actually make a small cut into inferior medullary velum. You can, and then even if necessary, do a little bit split of the vermis, you can actually also get the same sort of exposure, right? And so again, this is what basically the incision is divided in three parts. The first part, you open up the tilia choroidea, you begin inferiorly, and then you near the foramen majondi, then you extend upwards to the level of tilia. The second part involves extending incision superior in through the inferior medullary velum, so you expose the ipsilateral spirolateral recess. And then the third part, you actually goes between the tonsil and the medulla oblongata, forming the tilia, and you actually remove that, so you get a lot of the lateral recess. Now, this is a comparison from one of Roten's articles saying that actually how much you can get comparing a transvermium approach versus a superior this is a tilovelar approach. But I think that actually, you know, it all depends. And the other thing, of course, is that there are several key aspects: the direction, the route of the approach, structures retracted, sacrifice, the direction of retraction, sutures, structures limiting the exposure, and the areas exposed. So what is thought is that lesions located predominantly in the vermis extending into the ventricle accessed by the transvermial approach. Tumors located on the epidermal surface floor of the fourth ventricle often do not invade the cerebellum, can be accessed using the tilovelar approach. And tumors of the fourth ventricles not infrequently extend to the lateral recess, and this will be things like the ependiomas, and they may be best approached by using the tilovelar approach and then elevating the ipsilateral tonsil. Right. So, in summary, then the transvermial incision advantage of being a midline, right? But with the tilovelar approach, gentle retraction can actually get you very near the midline, right? And then the obex, the sulcus of the medulla, and the foramen majondi actually help to provide landmarks when you are doing the surgery. So there are advantages and disadvantages. So better working angle with transvermial, better visualization of midline. But then they said that the transvermial approach is limited lateral approach, and the lateral limit exposure is better with the tilovelar approach. And of course, if you are incising the vermis, you might cause neurological deficits. But my belief is that actually what you see in the cadaveric anatomy studies, they may not completely reflect real-life tumor surgical anatomy situations, because tumors grow, they enlarge, they alter the anatomical structures. The direction of tumor growth also deforms these anatomical structures. And then the presence of other pathologies such hydrocephalus and even the surgical procedure, what you actually do, how you cut, also will alter the surgical anatomy. And I know that surgeons who are experiencing only one or the other approach usually do not have problems with their surgical approach when they're approaching fourth ventricular tumors. But nevertheless, I think an understanding of anatomy will be very important to guide our surgical approaches. Right? Okay, just give you a videos to show. These are very quick videos to actually see how we do a transvermial approach here. I just burn it and you cut. And usually many times you don't have to cut very deep because these tumors are rising up. And as you open up, actually you will see these tumors, see the tumor, and you can start dissecting it already. Okay. And then as you progress on, you'll find that I just debulk the tumor, and actually these tumors generally like the medulloblastoma here, they're very soft, and but they're very vascular. So you have to make sure that you control bleeding. And as soon as you see the white, you know that you're on the floor of the fourth ventricle, and therefore you should protect the floor. Then once you have done that, you clear most tumor, then you need to go to the site to make sure that you are able to sweep out the tumors and remove everything. And you can see actually the post-op scan do show that they are quite good. Now with the tilovelar approach, especially when you see tumors sticking out, actually many times just by simple dissection around here, you can get access to the tumor. Right? So I'll show you a case where we actually have already dissected out, and you can see that actually you can start to see the tumor being exposed quite easily. Okay, so this one we're just exposing, and then we'll take putting in to take some biopsy. You can see this tumor on the scan is actually coming up quite low. Okay, and then you can see that, you know, this tumor is much easier to come out, you can see. And then you can even start to pull out the tumor, because many times they are not that badly stuck down. Of course, over time, I mean, as you go along, you find that things get stuck, and it can get quite vascular as well. I'll just go quickly, and you can see in this case, the tumor comes out quite nicely, although there's still quite a lot of tumor left behind because it's a very big tumor. Again, you see the floor of the fourth ventricle, so you must avoid any damage there. That's actually, to me, a very important landmark when I'm there, okay? And you can see here quite nicely that you can see the floor, okay? And then you can see as you finish it, right? Everything is clear.
Dr. Wantu, you have 1 minute to conclude.
Oh, I'm sorry. Okay. Right. So anyway, the ependymomas are actually much easier because they all come out and you can actually get it done quickly. But sometimes they're quite complicated like this. And these are the ones that it looks like very, you know, but you can still do it with one single approach. Although in this particular case, we have to come back to get the tumor that's left on the other side, right? And then the role of the vermis and cerebellums, I don't think a transvermin approach is really associated with posterior fossa syndrome or cerebellum, right? Because there are also reports of posterior fossa syndrome occurring with telovelar approaches. And so that, you know, it is evidence that does not implicate vermin injury. In fact, it is probably due to what we call the proximal efferent cerebellar pathways that actually cause this problem because it's a diastasis, right? And so I think those involvement, we know there's significant risk, but there are a lot of other things that may cause cerebellar mutism. Okay, so in summary, I think common posterior fossa tumors include medulloblastomas and so forth, right? So two main surgical approaches, transvermin, telovelar, right? Tumor growth location may one approach easier than the other, but in experience, and I believe both approaches are equally effective. So it's important to know and understand the surgical anatomy to avoid vascular defects and complications. And familiarity with the surgical anatomy also make our life much, much less stressful. Thank you very much.
Thank you. I think I will pass the moderation for Professor Igor Maldonado and Rames. Please, if you can take over the moderation.
Well, just to remind everybody who's saying that we are still going to hold the ISBN in 2021, okay? And the IFNE as well. Thank you.
Yeah, thank you. Thank you for your lecture. Professor Wan. I'll take a look if there are some active questions for the audience. There were no active questions. I saw in one of your slides, you mentioned cerebral angiography for hemangioblastomas. Actually, I'm not sure it would be a unanimous practice in many centers. In our center, for example, we don't do it in a routine basis. In children, because, you know, for angiography in small children, it means another general anesthesia. So what's your politics on this?
Okay, so number one, it's actually a very uncommon condition. Okay, but the concern obviously is that hemangioblastomas can be very vascular. And, you know, in children, you cannot afford to lose a lot of blood. So I think anyway, and it's, well, it's not, so because it's not so common, but it's something that we just put inside to make sure that people do consider that. It doesn't mean that you have to do it. Like in the case that I showed, we didn't have to do it because it was quite small. But if you see a bigger one, you may need to do that because if you obviously have a way to embolize some of this, it will make life very easy for the surgeon. Because children cannot also afford to lose as much blood as adults. So it's just a precaution that you can take. It's not, I wouldn't say that it must be done in every case.
Okay, thank you. There is a comment from Professor Broglie.
Yes, well, I would like to raise one problem that is also raised by Ibrahim's mate. That means pre-op shunting or pre-op external ventricular drainage versus third ventriculostomy or nothing. What is your opinion?
Okay, so routinely we will put in external ventricular drain if there's hydrocephalus. We don't do third ventriculostomy because not because I don't like to do it, but because to me, it's still a big operation for a patient because some of these patients will not require. So most of these patients that we have, they do not require a shunt. And so they may not also require a third ventriculostomy. I think most of the time what we do in practice is with a hydrocephalus, we put in external ventricular drain at the time of surgery, just before we start the craniotomy. And then usually over a 3 to 5 day period of time or a bit longer, we'll wean it off. And majority of our patients do not need a shunt after that. If you have removed the tumor completely, obviously you leave a remnant and there's still CSF obstruction, then the patient will need something. Then we can consider whether to do an ETV or a shunt.
Okay, thank you.
Igor?
One point I agree with you regarding looking at the origin of the lesion to decide transvermian versus kilovelar approach, and regarding medulloblastomas, which they originate and infiltrate the vermis. Do you think kilovelar approach in these cases compromise the resection of medulloblastoma? It's an argument that keeps coming on and on in all pediatric meetings.
Yeah, actually, to me, I have been doing a lot of, ever since I first trained and started, I always do a transvermian approach. And many times, because the tumors are so big when you see them, you open a bit of the vermis and you see the tumor. I suspect that people who are doing a tilovella, they might inevitably have to open up a bit of the vermis to get. So in the end, actually, you still have done the same thing. One, you start with the vermis incision first and go down. The other people probably do the tilovella approach and then start splitting the vermis at a later stage to get everything out. I don't know. It may not be true for small tumors, but certainly for big tumors, I think in the end, you do end up with quite a bit of dissection. So, but I think the more important thing, I can tell you that the rate, because one of the arguments for people saying about avoiding transvermian incision is the incidence of cerebellar autism. But actually, in my experience, the number of cases of cerebellar autism actually is very low, even with transvermia. I think the ones that we see are those that are very extensive, that actually may have infiltrated into normal tissue much more than the standard medulloblastomas.
As I understand, the dentate nuclei are close to the midline. So if you are generous with your transvermian,
exactly. So exactly,
and this is the origin of the mutism rather than the vermis itself.
Yeah, I mean, I think with a transvermian section, what you might get is a bit of broad-based gait, and you see that in the children when they come in the first few weeks, but if they in 6 months' time, you don't see any difference. Some of them still have some broad-based gait, but they are running like normal children because they adapt to some of these minor deficits.
Yeah. Shall we move to the next presentation, Ramesh?
Thank you very much.
Thank you. Thank you. So next presentation is from Professor Kanan. Professor Kanan, he needs no presentation. He's the chairman of the WFNS Neurosurgical Anatomy Committee. He's professor of the Department of Neurosciences in Fajr University in Riyadh, Saudi Arabia. So please, Professor Kanan.
Thank you, Igor. Well, I'll try to move fast. Please stop me whenever. This is the hospital. Pineal for the trainees, this comes from pine cone. This is a very sacred symbol for silver cultures, from the Phoenician to Canaan to Greek. And you see even the Egyptian, let me see, it's hidden. They call it the third eye, and I'm telling you why. The origin of pineal is like the pituitary and the hypothalamus. They come like the neural system from the ectoderm at the 7 weeks, where pituitary and hypothalamus comes on the 4th. And there is a close relationship between the two structures, and it has a role in infertility. They found that melatonin can counteract the gonadotropin. This way you get precocious puberty in some cases of the pineal region tumor. They call it the third eye because geometrically is in the center of the skull, but there is some link with what they call parietal eyes in reptiles. They give the sensation of light, the feedback to the pineal gland, and pineal gland will respond to this by secreting melatonin. Of course, except crocodile, they don't have this parietal eyes. I thought this is some kind of fact and trivia, you should be aware of it. And it was a mistake for the esoteric spiritual tradition. And usually it was in the 17th century where they felt that this is the gate of control for spirit, soul, and thoughts. These are few information. The Hemophilus in Latin written with U, in Greek written with O. He was the first to report the existence of a pineal gland, and he described the torcula, of course, which means the wine presser, 300 years ago. And the guide to follow Galen, he described the pineal gland. Both of them, they are Greek, born in Turkey and lived in Egypt. Very interesting story. Descartes, the famous mathematician, was the one who gave the functionality as the spirit controller. In the 16th, 17th century, he published several manuscripts and books about the function of pineal, but he never realized the actual function of it. And Delicourt was the first to report a tumor in the pineal gland more than in 1717. Studinka proposed the function of the gland, but a dermatologist was the one who has a lab who discovered the hormone melatonin. So there are challenges, and when we talk to the trainees, we want to teach him anatomy in that context. It's a deep-seated structure, difficult to access. It has can be afflicted with different pathology, which was mentioned earlier, and embraced by important structure. And the both thalami, the corpus callosum, the furnaciform top, and this gland, it has, like the pituitary, a stalk, two stalks, one superior, one inferior, and it's situated between the two commissure, the habenual commissure on top and the posterior commissure, which is the important structure when you deal with epilepsy and functional hemispherictomy. And it's a complex anatomy. If you take the pituitary gland, the complex anatomy comes from, and the suprasellar area, from the surrounding arterial supply, the circle of Willis. Here we have a venous supply, venous drainage, very complex at the level of the pineal, sitting on top of the pineal gland. We have to be aware of it and its anatomy. And this is what it makes it very challenging when it comes to surgery. Now, thanks to the MRI and MRV, we can evaluate the gland position, we can evaluate if there is a tumor, and we can evaluate the deep venous structures, which are very important during the decision-making of surgery. These are the type of lesion that Dr. Poggi mentioned. It can be from the gland itself, whether it's a glial, germ cells, or pineocyte, or it comes from the surrounding structure. The dural notch and the sinuses, they have the cap cells of the meninges that will lead to meningioma, and other remnant tissue like in epidermal cells and remnant for craniopharyngioma development. Metastasis and lymphoma can occur there since there is no blood-brain barrier in that area. And of course, Henry will talk about the pineal cyst and non-neoplastic lesion. And of course, aneurysm, vein of Galen, this is a venous malformation. A clinical presentation, if you just recall what is the surrounding area in that area, you have the aqueduct in the front, you see that big lesion compressing the aqueduct. So hydrocephalus is one of the presentation, and usually they call it the triventricular hydrocephalus because it takes the third and both lateral ventricular enlargement. And the tectal area, will, if it's compressed, you will get the paranoid syndrome. It's mainly an ophthalmological presentation, or you can be selectively affecting the fourth or the sixth nerve, the fourth because the origin comes from the lower part of the tectal area and embraced the midbrain from the back to the front. If you get the fourth nerve, you get the vertical double vision. If you get the sixth nerve, you get a horizontal double vision. The history of pineal surgery goes long back. And I want to give these two statements from Dandy and Cushing. Cushing actually, 1933, three, he said, look, it's not worth, I don't have the sufficient effort to take care of a pineal region lesion safely. So he did not touch it. With Dandy, he spent 10 years, he was the first to describe the approach to pineal region through his posterior transcallosal approach. And he realized that was a major morbidity. It took him 10 years before he started getting some successful procedure. And there were 6 or 7 mortality in these events. These are the names of the doctors. They have tried, Horsley tried, but failed. Krause was the first to try, and he tried the tector plate lesion in his publication 1913 in some sitting position. Dandy described the parieto-occipital transcallosal, and Horax was the first who described the occipital transtentorial that was eventually modified by Poppen, Stein, and more recently Ausman. 1988, he published the transtentorial approach occipital with the 3/4 bone to benefit from the gravity to mimic the infrasupra. The 3 main targets of a surgeon dealing with the pineal, he has to deal with the hydrocephalus. He has to establish diagnosis, because some of them, they don't need surgery. In Japan, 70% or 60% of pineal region tumor, they are dysgerminoma, and some of them, they treat them by trial of radiation therapy, and they see the response. And of course, we have marker for this to confirm the diagnosis and CSF study. And resection of tumor outside the germinoma panel of tumor, like a meningioma, pinealocytoma, all these tumors, they are in the potential for resection, and the surgical approaches, they are several, but these are the most common 3, which is the infrasupra, this is number 1, and the occipital transtentorial, and the posterior interhemispheric transcallosal. Of course, in the recent years, about more than 20 years ago, there was invention of the endoscopy to take a biopsy while you are doing the third ventriculostomy, and we did that more than 22 years ago, and we published. The stereotactic biopsy in general has been abandoned. It's a risk for sampling, a risk of bleeding. Usually midline structure is not the favorite target for stereotactic biopsy, but we did it 25 years ago where we didn't have the very productive approaches. So we elected to take a stereotactic biopsy. Is not without complication. A rate of bleeding was published in one of the papers, almost 25%, that went down to 9%. But now this approach is almost abandoned with the invention of endoscopy and navigation. So how you select the approach, this is the most important for the trainees. Not only by authoritative approach. The tumor location, is it a midline? The size of the tumor, is it within the size of 2 centimeters or larger? Is the tumor extension, if it's extended more laterally, a midline approach might not cover or take care of that. Although some of them, they said they can take more virgin vein on the site, I will talk about it. The vascular anatomy, the venous system, how it's allocated around the lesion. And some of the lesion in the pineal region, they are extended high up through the corpus callosum. You need an approach that can give you that window. And the one important thing people neglected, but they confronted while they are in surgery, the tentorial angle. If the tentorium is very steep, that might be a nightmare to reach that lesion, especially in a child with the small posterior fossa. And of course, this is why I mentioned there is surgeon preference. If I ask now Dr. Vladimir, your favorite, he will say infrasupra, no doubt. And I agree with him for a midline posterior. But if you ask Dr. Kobayashi, he's half the size of Dr. Vladimir. His favorite is concord position. And that's why he invented the concord position to deal with this one. So this is not only a stamina to build, but a physical structure. I will start with the infra-supra advantage orientation. This is a midline orientation is perfect. The gravity is not only aiding by non-retracting the cerebellum, it reduces the tension within the venous system. So you are not dealing with dissecting an engorged venous system by other position. This is one of the advantages. And it's a good exposure when it comes to midline, but if it goes extremely lateral, it might be difficult. Or if it goes extremely high, it might be difficult. And the beauty is no structure involved. So if you go, you are not penetrating any tissues, that only vermian vein you coagulate. In most of the cases, no trouble. If you coagulate near the output of the basal vein of Rosenthal, there are reported cases of thrombosis and catastrophic fetal venous infarction. This advantage, it was mentioned, the ergonomically surgeon fatigue. I was surprised that Bob Spetzler, with his wide range arms, he should be the least complaint of this one as compared to Kobayashi. The difficult access to lateral, I mentioned, air embolism, now with the semi-sitting position, with the protective measures, with the type of gas given, there are, irrigation is very essential from the start when you start drilling. This is very important. Hypotension, I don't see it that much nowadays as in the old days with the stagnation in the pelvis blood supply. Difficult in young children, yes, and because as I said, Professor Lepra did 176 cases in sitting position. I think when you get the anesthetist acquainted with the approach, you will be much better. Problem when they have a smaller posterior fossa and a steep tent, as I mentioned. Quadriplegia, we don't see it, it was written. There are modifications mentioned, a unilateral paramedian approach for a cystic lesion. This approach is a nice approach. You don't deal with the whole power craniotomy. And it was published by couples, actually. Many came from Japan. There are others published it. But it gave a limited presentation and exposure. These two stitches, they are very good stitches. You put them from deeper side to pull on the tent, which is to give you a more, sometimes you need the 2-3 millimeter exposure for these cases. This is good for lateral, the paramedian. You can go more lateral, you can incise the tentorium there, and you can achieve a lesion resection, like here, it was a cavernoma that was attempted to be taken out. The 3/4 bone, I like it. I like it for the type of tumor I'm seeing. A large tumor, it won't be amenable with safety to go only purely supra-infra. If it's extended laterally, you need that approach. And it gives you a wide approach, no doubt. If you incise the tentorium, not at the level of the lateral sinus, just in front of it, toward the tentorial notch, it gives you plenty of space down and up. And you are, the only disadvantage, you are eccentric. You are not going, orientation is not the same. You have to be acquainted with this approach, okay? And it handled lateral extension, superior and inferior extension. So it gives you an expansion of the approach, which you can like. And you can complement it with the posterior transcallosal if you need for a large tumor. Disadvantage, the contralateral side might be hidden behind the cardiac system, or it might be restricted by the Falx therapy that you'll be able to resect it. I will show a video that I took meningioma in that approach, and I'll go and show you a nice infrasupra with the endoscopy. This is a lesion, very smooth for a meningioma, but it tends to be a meningioma. And the tentorial notch meningioma at the galenic system. So we want occipital transtentorial, the occipital lobe on the right side, dependent by the gravity. And I'm seeing now the tentorium and the falx. I'll incise, coagulate and incise. I move a little bit fast. I put the stitch so I can move the falx right and left. Use the monopolar to cut the falx, so I will be on both ends. so I can reach to the tentorial niche and coagulate blood supply if anything coming from the castenary vessel. I'm seeing the tumor immediately. I'm start working. The distance here is shorter. It's not only by my own report, but it was a study published by the Japanese group where they evaluate the depth of the exposure. The supra-infa, of course, the tentorial shape gives you a longer access. A longer route to access the lesion. Here, you have a relatively shorter route. In supra-infa, you can counter it by going paramedial. So I'm disconnecting. I apply the rules of 5D meningiomas, devascularization, decompression, and then the dissection. I am on the tumor and dissecting and apply the rule of the arachnoid. Belong to the patient, so we try to keep the arachnoid. This is central debulking with the CUSA. Now put the patty on the normal tissue. Just working on the tumor and mobilize it, and the patty comes underneath to cover the arachnoid. And now go around another sectional decompression. Take the tumor off the cerebellum. So you see the arachnoid down. And the patty will protect the venous system covered with the arachnoid. So it's a fantastic approach for a meningioma that is not encasing the venous system. Arachnoid. And this is the post resection. Okay. The other approach is the posterior transclival. This is not my favorite approach. You are handling bridging veins of the areas that can be affecting the parietal region, the motor strip, and the sensory strip. You get potential complication. The other complication from the occipital transtentorial, I forgot to mention, is the occipital cortex. It can lead to cortical blindness if you are doing a bilateral. So you have to be careful with the amount of retraction. This is the advantage putting the patient 3/4 prone. This has been studied by the Japanese group, and without the tilt, they have a high percentage, 20% of occipital ischemia or hyperperfusion. They find the mechanism of hyperperfusion that it will last 3 months before they recover. But by the Osman approach, this complication is almost negligible. So,
you reached 20 minutes, Imad.
Okay, this is stereotactic biopsy. We've done it 25 years ago. We just took the biopsy and give radiation, and now 15 years after, he's still in remission. This is, we did it 21 years ago, where we went to do the septostomy with the navigation, and we tilted the projection to take a pineal biopsy from the anterior third, through the third ventricle biopsy and giving radiation. This is the video I'd like to not to miss it. I want to show it to you, that we complement the infrasupra with the endoscopy. This is a lesion, size of it. This is a microscopic picture. Now this is the endoscopy. The endoscopy gives you a fantastic view. Unfortunately, the holder was out of air, the pneumatic one. I have to do a dynamic like what I'm doing in pituitary. This is still in the microscope, trying to mobilize the arachnoid and the venous system above the vermis. But I will put the endoscope and I'll show you how nice the picture and how much you can achieve. Now we put the endoscope, we enter the third ventricle, the lesion going into the third ventricle, and there is a lesion here. And you see the massa intermedia, the aqueduct, posterior commissure, and we'll start mobilizing some of this tumor from the side of the choroid plexus. I'm taking tumor from the pineal region. I need to conclude soon here before. We achieved a subtotal resection. It was pinealoblastoma that will need radiation therapy. But there are lesions like this. What approach is the best for this one? See how steep the tentorium. And this might need more than one approach. With intact major venous sinuses, you have to be careful as well. We don't want to damage. There are complementary treatment. There are non-surgical options like radiation therapy. Stereotactic radiosurgery has been trendy now for some localized tumors. And chemotherapy, the 6 cycle they give for the dysgerminoma and blastomas. Tumor markers is of a great help to avoid surgery if they are positive in the germinomas case, and significantly important for follow-up and evaluate recurrence. The whole message, adapt and tailor authorized approaches. We are not saying it's infrasupra is bad or occipital bad. You have to learn all these approaches and guide by the size of the tumor and the location, and embrace innovative approaches. And I thank you very much for listening.
Thank you. Thank you, Imad. We'll have 1 minute maybe for a short comment. One of the panelists.
Okay, let me, Igor, Imad, both you and Jani has said that the ergonomics is a problem, that you have your hands elevated. It's not true. If you position the patient properly and if you bend the table a bit forward, and if you have a good armrest, then your hands are virtually horizontal. So there is no fatigue. It's not really a big problem. And this is especially true for unilateral approach, which is not as steep. You know, if you come from the side, the tentorium is not as steep as if you are approaching through the midline. Although the midline approach needs sacrifice of few veins coming out of the vermis. If you use unilateral approach, you do not need to sacrifice these veins. So these are only 2 remarks, but otherwise it was a great lecture, especially with historical remarks. I loved them.
You see the point I mentioned, this benefit and disadvantage. You're going paramedian, less venous and less steeper, but right. you cannot take a big lesion. You are guided by the lateral part. You cannot expose beyond the 4th nerve. And this is the limitation in this approach. So it has this limitation. Fatigue, if you take 10 surgeons and doing sitting position, they would tell you they are fatty. Like praying, you see, you can pray with your horizontal arms, but you can pray with the arm down. And this is what the difference. I don't want to be 6 hours like this in all cases. I'm not saying this case, the infra-supra is a bad approach. I mentioned it. This is my favorite for pineal region in specific. When it's in midline, not extending laterally, superiorly. Now, inferiorly, you can overcome it with the endoscopy like what I showed. It was inferiorly oriented and anteriorly oriented. In the old days, they said this is against the indication. It's not, because you can, with the endoscope, have a longer reach than what you are usually used to. But thanks for the comment. I anticipated that Vladimir will be always saying infra-supra.
We were waiting for a comment from Vladimir, right? Okay. But from Vladimir, it's easier to have the arms down. Do you agree?
You can even enter the fourth ventricle easily. If you make a small paravermian cut into the cerebellum, you are in the fourth ventricle. So,
sure,
it's excellent approach, no doubt about that.
So we must move to the next presentation. I'm sorry. So I'd like to call Professor Henry Schroeder. Professor Schroeder has been with us in other versions of this webinar. He's a professor of neurosurgery and chairman of the Department of Neurosurgery in Greifswald, Germany. Henry? You are mute. You're mute.
So hello, everybody.
Thanks for coming.
Thanks again for the kind invitation. Good to see you all. Good to know that you are doing well. Imad, can you give me your screen?
Yeah, can we get, I will step out. Would you try, please?
Do you see it?
Yes, yes.
Sound is good?
Yes.
Wonderful.
I have a 100 Mbit line now. Now it should be good.
Okay. You will be a baritone today.
Yeah. Okay, so my topic is unilateral paramedian keyhole approach, which we mainly use for pineal cysts, but also for pineal tumors. And Imad has told already about the pineal gland location, and so I can skip that. The main function seems to be a light-dependent melatonin secretion, so it's important for sleep-awake rhythm. And you know, some people consider it to be the place of the soul, but we removed already a lot of souls, but no patient had a bad outcome because of this loss. So although René Descartes said it's the place of the soul, obviously it's not. So the pineal cysts are very frequent. And in autopsy studies, up to 40%, they found cysts. And if you look carefully at the pineal gland, you see frequently very small multiple cysts inside, like you see in many glands. So that is not a pathological finding. Usually they are asymptomatic incidental finding, but sometimes they cause obstructive hydrocephalus, and then everybody's agreeing that is an indication for surgery. But there are patients, they have symptoms and they have small ventricles. And this is a matter of controversy. Some people say it's bullshit to make surgery. All these are psychologic impaired patients. They have other problems, but not the gland. But there are certainly some symptoms which are clearly related to a cyst, even if there are no dilated ventricles. And what we found frequently is headache. They have a pressure feeling in the head. Sometimes they have an attack of severe headache, and then they have nausea. Some of them vomit, and then the headache is released. So it seems to be that at least some patients have a valve mechanism of the cyst. Dizziness is a problem, visual problems, parano, and memory problems can also occur. So there are a lot of approaches. Imad has nicely shown all of that. But for me, the best for the pineal region is the suprasellar intratentorial approach, because you go directly to the lesion. You have no structure, which is important in the way to that. And when you look to the anatomy, you see you go just below the tentorium. It is a minimally invasive approach, in my opinion. It's not difficult to go there. It's a long way, that's correct, but it's not very important structures are here in your direction, but you have to be careful with the veins. And some people say the endoscopic fenestration of a pineal cyst is a less invasive approach than this microsurgical big operation. But I don't agree, because in the endoscopic approach, which we have also done in some patients, is you go through brain tissue, you cross the brain, and here you just go through a subarachnoid space. You never touch brain tissue. So that's why, in my opinion, this is the least invasive approach to the pineal lesion. We have to be careful about the steepness of the tent. That is very important, because sometimes it's really very steep and then it's difficult to go there. And of course, most important are the veins which are closely related to the pineal gland. And the major risk is that you damage one of these veins and can have an venous infarction, which really may cause severe damage to the patient. And the main veins which are at the roof of the third ventricle are the internal cerebral veins, and laterally we have Rosenthal's vein, and all go to the large vein of Galen. And that these four vessels must not be damaged. That is very, very important. So positioning, I also like the sitting position, because the cerebellum falls down by gravity. We make a paramedian incision 2 centimeters from the midline. And you see, initially in the beginning, when you look up to dissect the cerebellum from the tent, then the angulation is there. But you see, it's not much going up. And if the more you go deep to the pineal region, the more you come down, and the relaxer is a position. But I had one case where my co-worker was calling me and said, I cannot reach the tumor because my arms are too short. Then it might be a problem. Air embolism is a major problem of the approach. Some people say it never occurs, but I think that's not true. Everybody who's honest have some patients with air embolism. And to detect that early, before we have symptoms, we have this endoesophageal echo, and we can see the ventricles. We see any bubble of air in the heart, and that is very helpful to prevent problems. We had one patient, there was a lot of air. We make a Jular compression test. We could not see any leakage. And then we had to keep this compression. And when they released it, again, air was coming in, and we checked everything. There was no visible leak. So maybe it was a valve mechanism. Maybe it was supratentorial located. So I don't know. After a while, it stopped. Obviously, there was some coagulation of the blood, which closed this leakage. But this was just one case. When we have a permanent foramen ovale, and we know the air might go from the right heart to the left and cause direct embolism in the cerebral arteries, then we do this prone position, and it's not concord, it's a little bit in between concord and prone position, and we do the surgery. That is safer. Some people say, no, it's no need, but we go the safe way. So the traditional approach, what I learned when I was a resident, was that we make a large opening. The transverse sinus was unroofed. Then we make this incision. We open the large cistern. Then the veins were coagulated, and then we get the approach to that. So here's one example. The arachnoid is dissected. Sometimes you have only small veins, but sometimes, you know, the veins are very thick. And this is interesting. The venous anatomy is so variable. Each patient is different. So then usually you have a very thick arachnoid covering the veins, and you have to be very careful that you do not mistake the veins as an arachnoid layer. So that's why jugular compression, if you are in doubt what it is good to make sure that you do not cut into the major veins. And then you can dissect small vessels feeding the pineal gland where coagulated and cut. But in general, the dissection of the pineal gland is just done with 2 forceps. There's such a nice plane around. It's not much adhesions, only a few blood vessels. It's different to some tumors, but in pineal gland cysts, it's usually a very nice bloodless dissection. So this is for the traditional approach. But the paramedian keyhole approach, which we use since 6 years or 6 or 7 years, is much better, especially the trajectory. Vlad already mentioned, if you go midline, the steepness of the tent is very high. As much as you go lateral, the angle becomes flatter and flatter, and it's almost parallel. And then it's easy to get it. That is a big advantage of this approach. So the incision is paramedian. So we feel here, this is an external protuberance. So we consider that the transverse sinus is running in this level. And this is the incision, or 1.5 to 2 centimeters lateral of the midline. Then we open the skin, and we have to be careful because in some cases we have the greater occipital nerve in the incision. And then we have to be careful because if you damage it, this can really cause neuropathic pain and can be cumbersome for the patient. So we always look to it. So we incise layer by layer, and then we find the nerves, and we mobilize it and bring it down. It's another patient. Sometimes we have also 2 nerves. So we are very careful with this nerve, but usually you can retract it laterally. Craniotomy, ideally, the first borehole is directly on the transverse sinus or a little bit above. Usually these are younger patients where the dura is not very attached. If you have an old patient, then of course I would not do that. But in the younger patient, usually the dura is not very sticky here. And we just place it over the sinus or a little bit above, but not below. That's very important. We want to unroof the sinus. And then we take a craniotome and make an opening around 2.5 centimeters. And then with jugular compression, you see where is the border of the transverse sinus. You see this is the size of the craniotomy, what we usually have. Dura incision is just parallel to the sinus, and then we have 3 tacking stitches to lift it up. Especially this one is lift up very much, and we see here a small space. And then it's very important that we look to the veins. And you see after the surgery, if you release CSF, then the cerebellum goes more down, and really there's no retraction required. Closure is done just by a running suture. If there is a leakage, we take a little bit muscle sutured on it. Then if we are in doubt, we take a Tachoseal to place it over it, not in all cases. Then gel foam is put into the craniotomy defect. The bone flap is fixed with titanium plates. And then we make a layer by layer closure of the skin. Take careful again with the nerves that you not suture it with your subcutaneous or fascious suture. And you see the incision is around 5 centimeters. When we plan the approach, it's very important that we look at the height of the transverse sinus and at the bridging veins. So when you look here, you see one sinus is more up, one is lower. Then usually we go to the upper because then the angle of approach is not so steep. And we also look where are the veins running. There are usually bigger veins in the midline and not so much laterally, but sometimes you have also lateral veins. So the venous anatomy is extremely variable, and we have to look very carefully at that. For example, here, bridging vein. We looked here at this patient, and the decision was made to come from the right side because this was a smaller non-dominant sinus on the right side. But you see there is a vein, but we thought it's laterally and it's not big a problem. It goes lateral to the tent. Then we open it, we saw, oops, not good. There's a big bridging vein, there's a big bridging vein. And you see there are multiple small vessels going to this major brain. So I think I don't like to coagulate it. So we cut this vein from the tent to preserve it. You may argue, man, nothing will happen, you can take it at least, but I try to preserve as much of venous anatomy as possible because I have seen that there was swelling in the upper part of the cerebellum after coagulation of a major bridging vein. There's another patient. We looked to the side and said, right side is a big vein, left side is a small vein. And no, sorry. We said, yes, on the right side, we should, the right side is a big vein and here is a small vein, so we should come to the left side. But if you look here, further, in the middle of the tent, there are 1, 2, 3 veins, and I have overlooked this. I just looked here, one bridging vein here, one bridging vein here. This is thicker, this is smaller, so I come from the left. I did not look here. And then when we came in, we saw one vein, another vein, and the third vein, and all of these are really thick. The sucker is 1.5 millimeters, and you see these are really big veins. So I would not dare to coagulate these. It was a child. So that's why I dissect the arachnoid around the veins. You see 3 bridging veins, similar size. So I take the arachnoid with 2 forceps, and then I dissect it away to release the veins from the cerebellar surface so that the cerebellum can go a little bit down. Unfortunately, it was possible. But you see the windows in between the veins are only a few millimeters wide. So I had to mobilize the middle vein from the cerebellar surface so I get a corridor. And then I use the microscope because I have always one eye on these veins to see how much retraction I do. And then I dissect it in between these 2 veins to get this out. And this for me is also one example to show that the microsurgical approach for these cysts, in my opinion, is better than the endoscopic one. Because if the endoscope is in and you move your instruments, you will certainly rupture one of the veins because you don't see it. And with a microscope, you have not that good visualization in the depths, but you see always what you're doing with your instruments to these veins. And you see after surgery, all veins are still there. So I try to preserve all the veins. Cyst dissection is easy. The first thing is cutting off the arachnoid, overlying the bridging veins. Then you see this greenish structure and you open it. And then you have this nice plane around the cyst. The cyst is big. We open the cyst and then we dissect around. We dissect it away from the thalamus on the left side, right side. Usually it's not very sticky to the tectal plate. And then finally we dissect it from the telachoroidea, and we have to take care about the internal cerebral veins. And this is after the surgery. You see this is a great vein of Galen. These are vein of Rosenthal from both sides. This is a telachoroidea. You see one internal cerebral vein is the other one. Here again, this is Rosenthal vein, internal cerebral vein, and this is a Vermian vein in the middle, and all these veins drain to the vein of Galen. And here's habenular commissure, and this is the posterior commissure. This is the fornix anterior commissure, and this is a tectal plate. So all these can be visualized again, anterior commissure, fornix, foramen of Monroe. And this habenular commissure, we tried to preserve it, but there were some large cysts where it was just a thin layer, and we could not preserve it, but obviously there is no obvious psychological deficit or neurological deficit when you cut this habenular commissure. So what is the indication? This was a 31-year-old female with headache, double vision. MRI shows a pineal cyst, but you see the aqueduct is completely normal. So I sent her to my eye doctor and he said, no, the eye problems are not related to this cyst, cannot be. This is something else. And then I said, no, I will not do the surgery. The headache might have other causes and your eye problem is not related. And then she became angry with me because she was from England and came just for the surgery. And she forced me to do the surgery and she had to sign that obviously there will be obviously no benefit for her regarding the vision, but she forced me to do that. And then I said, okay, we do it. Then we removed the cyst. You see here, 2 days after surgery, MRI is good. She went to Berlin and then she wrote me the first message, and I'm pleased to say that all vision has returned to normal and prisms are no longer needed. And I thought, placebo effect. I call her 1 year later everything is going great. Vision is great with no prisms. Migraines have also stopped. And then I asked her again 1.5 years later, and she was very happy. And that is for me very strange, because the cyst was small, and my philosophy was there was at least a temporary aqueductal obstruction which was causing the problem. Another patient, 10-year-old boy, vomiting, no headache, but a large cyst. So he was almost free of symptoms when he came in. But I advised here we should do the surgery because the pineal cyst is obstructing the aqueduct. You see, he has already ventricular dilation, and we do the surgery. Here again, for the approach planning, you see the right sinus is a little bit higher, and there's a big bridging vein on the left. So we come from the right side. This is the paramedian approach again, 2-centimeter incision. You see here on the lateral side, there is a big bridging vein. So we avoid this. And then on the right side, we open the arachnoid. So I would not do it with an endoscope because I would be afraid that I really damage the small bridging veins. That's why I use usually the microscope to dissect, because then you have more space. If the endoscope is in, you know, it needs a little bit space. So we open the cyst, you evacuate the cyst, and then it's a very nice dissection. You see, we have 2 forceps. I grasp the cyst wall, and then I dissect. This is a telachoroidea. The cyst is not very sticky. Some small vessels which are coagulated. This is habenular commissure now here. Habenular commissure is dissected from the cyst. And here you see the thalamus on the left side. Very nice plane going around. And then finally from the tectal plate, where the cyst is not adherent, it's just the habenular commissure and sometimes posterior commissure. And you see very nice where's the border because of the grayish color of the cyst. So then you can use an endoscope to make an inspection. You see is the mesa intermedia here. Here in front is the foramen. You see the large vein. Here are the internal cerebral veins draining into the vein of Galen. And laterally, there is a vein of Rosenthal. And this is a bridging vein, which is still present after the surgery.
You reached the 20 minutes, Harry.
Okay, just now one case. This was very typical. This was a girl playing on the ground. The mother said the child was crying, "Aua, aua, aua." She vomits. And after vomiting, he starts again to play, as nothing was happened before. And she was treated for 3 years with different strange diagnoses. And then the mother sent me the images, and I said, yes, he is really in a compression at the beginning of the aqueduct. This cyst may cause intermittent blockage of CSF flow with a valve mechanism. And then we made the surgery. In this patient, we had to make her prone because of open foramen ovale. So we made the surgery, removed the cyst. You see the cyst is removed, and now 3 years after surgery, she's completely doing fine. So the question is, can pineal cysts without ventriculomegaly be symptomatic? And this was a paper from Charlie Teo, 18 patients, and they had 100% total resection, and 94% of the patients had improvement of the symptoms. And they conclude that in some patients, the cyst might be symptomatic. It's another paper in Acta Neurochirurgica, 27 patients, and they found when they make a gross total resection, 15 patients, the other had the shunt, and some had only partial removal. The patients with a total cyst resection were significantly better. So also our experience with 43 patients is that we had 41 patients out of 43 reported a good outcome. So there are certainly problems caused by pineal cyst. Is it urgent? I made a literature research looking for sudden deaths. There are some reports. This was initially it were only 2. Now when you look, I think about 7 or so. This one of the recent one was unexpected death during sexual activity due to a pineal cyst. So you have to advise your patients, if you want to have safe sex, the cysts need to be removed. Thank you for your attention. I think the paramedian approach is a very nice alternative to the standard approach, and it's sufficient to deal with pineal cysts.
Thanks, Henry. Splendid presentation. We have some minutes for questions, comments from the panel.
Vlad has to say something.
Yeah, I think he's going to say something.
We do it exactly the same way. We have like 150 patients which we follow only. And we did 30 surgeries. With the exception of one, it was successful. But what we now do is that we leave a piece of the gland behind. The piece of the gland which is in habeneural region, just to preserve some melatonin secretion for the patient. We do not know what the melatonin does, but we know that if we remove the pineal gland entirely, as you do it and as we did it, that the secretion is zero. We have published that somewhere. So by now we are leaving a little piece of the gland behind just to preserve the secretion. We do not know whether it works. We still do not have the data. We have few patients to come for melatonin levels measurements, but just in case, you know, there are some report that the aging is accelerated without melatonin, that the ladies do not get pregnant enough, that the conception is much more difficult. You know, nothing's sure, but melatonin definitely plays some role. So we like to keep the melatonin production for the patient.
Yeah, that is very interesting. I had one American guy or a lady, she wanted to have a little bit of the gland back. So I left a small piece, but I'm not sure that is really working. And the interesting thing is, even if you remove the cyst, sometimes the melatonin level is not lower than before. So the variability of melatonin in the blood seems to be very variable. So we always take blood before, when it is not dark, so before the evening, and then when it's dark outside, we take another sample. But it's very difficult. Also, what I have read until now, it's very difficult to say this is a normal value of melatonin. Do you have a different experience? And it's interesting. Some patients say after cyst is removed, oh, I sleep much better. Then we had 2 kids, they could not sleep for 8 weeks and they needed melatonin substitution. But after these 8 weeks, they are without any medications, they fall to sleep. And it would be nice to have a long-term follow-up of the level of melatonin in the blood. But this is difficult to get.
It's difficult to get, extremely difficult to get. We tried that and we didn't succeed. They say that melatonin can be produced in the lungs as well. So probably that is why there are some levels of melatonin. In our patients, there was really zero. And as to the sleep, we give to all the patients a questionnaire about the sleep, you know, for 3 months. They have psychology and they have this questionnaire. And we didn't see any disturbances of sleep.
Yeah, that's interesting.
In 150 cases.
Yeah.
But now it's very mythical, all this.
Yeah.
Very, very much so.
That's very interesting. I think also that the melatonin production is not just in the pineal gland. So it must be in other parts of the body as well.
Yeah.
For me,
probably not in all cases, not in all patients.
Yeah. For me, the major problem is to select the right patient for surgery, because sometimes they have really strange symptoms. There was one lady from Sweden. I sent her to the psychiatrist because I said, no, this is not the cyst. And she came back after 4 weeks, showed me the report. No, I'm not a psychiatric patient. Please do the surgery. And I did the surgery, and I really followed her now for more than 2.5 years. And she said, no, now it's much, much better. But maybe it's just a psychological effect. You never know.
Most likely.
Henry, both of you, can you comment on the placebo effect? Because it's really hard to argue. You have a cyst that has no obvious mass effect on FLAIR imaging. It doesn't obstruct the aqueduct. If you have a CSF pulsation sequence, you can show there's flow. But I also agree that there are, 10% of patients that have maybe local stretch symptoms of the arachnoid or, some form of nervous system imbalance in that location. I agree with you. It's very difficult to go for surgery in someone who seemingly has no compromise from an incidental lesion. And giving the numbers of these cysts, they are so frequent, it's very hard to pick the ones that actually will benefit from surgery and don't present with placebo afterwards, right?
I'm sorry, I think we're running out of time. Would you mind answering on the written window? Actually, I would like to invite previous speakers to take a look on the questions and answers tab. Just the last icon you have on your toolbar. There are some comments, written comments there, and the attendees are asking us to answer them. Thank you. Professor Kyrillos, would you mind taking the moderation from now?
Thank you. The next from Professor Eckhard Kasper, who gave us really fantastic talks throughout the series, talking about, from Canada, about torcular meningiomas. Professor.
Okay, can you make me share the screen, please? Do you see my presentation?
Yes, yeah, we do.
All right. So thank you, Martin Vladimir, for having me again. I'm very happy to join in with this talk on torcular meningiomas, and I think it actually follows a common theme of the last two talks. Martin Henry gave a fantastic overview of why venous anatomy in the P fossa is so relevant, and I hope I can build on that. Let me just see where we are. I have nothing to declare other than I think the only thing about torcular meningiomas that is good is their rarity, because they are really scary lesions. Especially.
Can you put it in the presentation mode?
Oh, sure. Slideshow. Presentation mode. Yes, here we are. So my agenda is I want to take you briefly through epidemiology, more for completeness of purposes, then through some of the normal anatomy. I want to take you through the pathological anatomy and the problem, and then go over to pre-op management and imaging, followed by surgical management, including positioning, which I think is key, pre-intra-op and post-op strategy, and then 1 point on post-op management. So from background perspective, not different from any others, the brain tumor patients do not discriminate. There are approximately 700,000 people in the United States having a primary tumor, which translates into 78,000 per year, roughly 50,000 benign tumors per year diagnosed. And if you want to look up the different types of tumors, I provided a pie graph for you for completeness. Meningiomas out of these make up about a third of primary brain tumors, equals about 25,000 per year in the United States. But the problem with torcular meningiomas is that they are super rare. The age distribution and gender distribution follows normal incident rates, which really means that females are disproportionately affected, which likely is due to hormonal effects, and especially in torcular meningiomas, there seems to be an enormous preponderance of female patients affected. Amongst the meningiomas, you need to realize that the vast majority is supratentorial, only 10 to 13% are infratentorial, and amongst the infratentorial tumors, this makes about 1 to 0.1% of tumors. So it's really a rare bird, but it's an important one to come across, because if it hits you, you need to be prepared. So what about the normal anatomy here? We all know that torcular is the junction of the superior sagittal sinus and transverse sinus, and you can see that it takes up the straight sinus coming down, and then continues sometimes as a cerebellar sinus, but also usually diverts laterally into the transverse sinus. And there's usually a dominant one of the two transverse sinus visible. The external landmark is the occipital protuberance, and we use that for surgical purposes. Your blood supply to this area, to the meninges, arises from the middle meningeal artery, the occipital artery, or meningeal branches of the vertebral artery. Now, what's so important here is the pathological anatomy. And torcular meningiomas are not subclassified themselves, so most people use a classification system developed from parasagittal meningiomas. This system by Sindhu is very helpful, breaking it down into about 6 types of tumors. Top panel number 1 is a tumor that comes and just attaches to the outer wall of the sinus. Then it invades the lateral recess, type 2. It invades one wall, type 3. I think those are the most important ones to remember. And progressively, type 4, it invades 2 walls or can even completely obstruct the sinus. And that will change your surgical strategy. From a clinical perspective, I think it's smart simply to say, is there partial obstruction or is there complete obstruction? And if there is partial obstruction, is it more or less than 50%? So I think one problem is obviously the location and the venous relevance in this arena. So you need to study your venous anatomical variants. We'll go to that in a second. Patients usually present with occipital lobe symptoms, which are visual, can be a visual aura, seizure, can be visual compromise, blurry vision, or hemianopia, or with cerebellar signs, which are by compression, ataxia, dysmetria, and nystagmus, or ICP elevation, mainly causing headaches and associated symptoms. Now, when you think about these lesions, you really need to study your venous anatomical variants, and especially the one second from the left that is mentioned here is the one we all know best. The normal superior sagittal sinus drains into one dominant transverse sinus, which is usually on the right side, and that is found in more than 50% of cases. But there are unusual draining patterns, either duplication of sinuses or atresia, as frequently seen as in 20%. And this is where you need to pay huge attention at the beginning of your case. Now, when is surgery indicated? First of all, resection is indicated, I think, only for symptomatic patients. I think below the age of 65, sometimes we operate on older patients if they are fit. And they should have either badly symptomatic tumors or enlarging tumors. And I think they need to be medically fit for surgery with the KPS above 70 is our average takeoff. I think surgery is not indicated for calcified tumors in this location or tumors that are not growing and just incidentally found. These patients should be observed with serial imaging every 6 months. And if the patient has significant comorbidities, this may not be the patient to try something out on. So symptomatic patients that are older or have comorbidities can be shunted if they have hydrocephalus, and then one can think about radiation therapy for the remaining period of their life. Now, learning points. I think the tumors that can be considered for resection are the ones that have already occluded the sinus. That's a good starting point. And the ones that have collaterals developed, and you can think about yes or no reconstructing the venous outflow. The more difficult scenarios where tumors have partially occluded the sinus, and here you need to really set your goal for surgery. Sometimes it's wise to go for subtotal resection followed by watchful waiting and possibly radiation. I personally do not recommend sinus wall resection and reconstruction in high-grade occlusions. If a single wall is affected, that may be different. I'll show you the data in a minute. So what do I do? This is a high-risk surgery, so I think you need to spend the most of your time on pre-surgical imaging. And I obtain plain X-rays to see is there bony erosions, possibly paraosseous venous channels, and then I get everything that's on the market, CT and CTVs in 3D rotational modes that show you venous anatomy in an overview, MRI scan for extent of tumor, but you really need a DSA to assess tumor supply and collaterals, because the problem with MRAs is that they are flow-based studies, and if you have low flow status, you may get a signal dropout that tells you there may be no flow, but in reality, there is still preserved anatomical flow. I think a PET is not necessary, but some people get it for pre-surgical staging to know how aggressive the lesion is. And then I follow an advice by Yajagil. He actually flips the sides of his MRI scans or CAT scans in the operating room, and I just print them swapped left to right, the same way I would position the patient in the operating room. And then I draw on my printout what is my surgical strategy, because I think this is such a complicated case that one needs to really have this staged out in your head before you get into the operating room. This is a similar paper that was published by Nagakawa that showed one of these pre-surgical scans and DSAs that gave him an idea about how to approach this tumor. They made a beautiful conceptual drawing, and it helped them really to stage the procedure. Now, why is a DSA needed? I said you need to define your dural sinus. You need to really study the collateral venous drainage, and you need to look out for significant transosseous and scalp drainage, because it may actually go laterally, and this may be the brain passage, the brain vein lives on. So think about this. Even the scalp flap and the craniotomy must be tailored to preserve these only outflow channels that are left to the brain if your torcular is already occluded, right? And in addition, you need to look at tentorial channels. One other thing for pre-incision adjuncts, you should not forget, this is complicated surgery, so give your anesthesia team the time they need. I think large bore access, precordial Doppler, as we said, for possible air embolus, get a large central short line, a cordis line in for possible aspiration. Keep your height of bed slightly elevated, and the anesthesia team needs to exactly know where the button is to bed control in case you need to change this. Have fluid ready to flood the team, the surgical field, and clamps in case you need to temporarily occlude or permanently occlude a large vessel. I don't use lumbar drains or EVDs because I think this is largely extraaxial disease and it's very superficial, but it has been described in the literature. I use definitely brain relaxation, 100 grams mannitol, 20 Lasix, 10 of Decadron is my usual cocktail, and I hyperventilate the patient to get some vasoconstriction to get more volume out. Now, I included this slide just for completeness, how to manage air embolus. It was well addressed by Henry's talk. Please look at this. It's a great article in the Gardol Neurosurgical Atlas and tells you how to handle this in case it does occur. I think you need to be prepared for it. In terms of surgical strategy, I think all positions are possible that work in your hands, but I urge you to think about this carefully up front. Nobody has the best answer for this one, but I think you need to think about your incision, and I definitely prefer a linear incision over a trapdoor or a barn. The reason is you can maintain better venous supply. So my recommended position for someone who does this first time is to do 3/4 prone. I stand to the shoulder of the patient on the right side of the images, so I look upright as if the patient's head is in front of me pointing up, normal anatomy. I think the position is great. It avoids rainous venous pressure from abdominal chest compressions. It reduces your risk of embolization. You can drop the head easily. The head should be turned slightly, and the tumor should be the highest point in your surgical field. Tape the shoulder down, otherwise it drops into the field and you have obstructed view. I think most of the torcular meningiomas require supra and infratentorial exposure. I start infratentorially, and the reason really is that I'm more awake and alert at the beginning of the case, so I'm a little bit more careful and get a little bit of a break when you do the supratentorial component, which is more routine afterwards. But that's a standard opening. For the supratentorial component, which is usually more relevant, I think make this as conventional as possible. So use your image guidance and just think about, wide durotomies. On the left side, you see you want to have clear margins of your dura. You want to tilt the dura away from the sinus. And then I use some stationary attractors with very little pressure because you need to be careful about the occipital lobe. And you need to prepare for double ligation of the sinus to make sure you have no bleeding into the field. Prone works also well. This is by Tetsuo Kano's atlas. Here, gravity helps you to have the brain drop away from the sinus. But as you can see in the picture, I think the opening is a little bit small. Aim for 2 centimeters of normal dura around your lesion. Now, how about sinus invasion? There's a great set of papers in respect to parasagittal meningiomas. This is one from Teed Madison that tells you good strategies and techniques. What I want you to take away from this is I think type 1 tumors are extravenous, so they don't need any grafting. Type 2 and 3 tumors just infiltrate the upper corner and one wall. These are the ones where you can think about dural patching, and you need to prepare for this. Grade 3 and 4 tumors, I think, are largely non-suitable. Now, cases to learn from for grafting is one of this. There's a fantastic paper said by Lalekam Shekhar that shows you this is a tumor on the left upper corner. You see that infiltrates one of the transverse sinuses, but doesn't occlude it yet. Here, the strategy is, expose the tumor as much as you can in the middle panel on the top, and then you plug the sinus left and right with a piece of Surgicel to allow you to remove the intravascular tumor component and patch a piece of pericranium into it. So this is a relatively simple repair with a simple patch for one vessel axis only. When it gets more complicated, like this tumor that is largely intravascular, you have a bit different problem. Here, the transverse sinus is not occluded, but the straight sinus is already occluded. So I personally think pick your battles wisely. Large part of the tumor here is extravascular. I would have resected that part. Shekhar takes you through the steps of how to open the sinus in all 3 walls and take out the tumor and patch up a repair. I included this for you to review. The reason why I don't advocate for a 3-wall repair of the sinus is that patency is really limited. More than 50% of sinus reconstructions will lead to complete thrombosis, even in expert hands. And Shekhar is one of the best guys out there doing this. So I think this is not for the beginner, but if you have good vascular training, by all means, it's possible. Now, how to deal with gigantic tumors if you're facing like seemingly impossible problems like this one? I think the most important lesson to learn from a case like this is define your goals, because it is essentially impossible to achieve a clear gross total resection in a tumor of that size and extension. So here, subtotal resection followed by radiation really equals quality of life. And I think De Bernardi discussed this very nicely in their paper, where they show over the last 10 years, patients now have increasingly the expectation of no morbidity associated with surgery, and they are much more willing to accept a subtotal resection in the setting of adjuvant therapy. Now, I want to take you through one of my own cases recently, which combines all these questions. This was a 21-year-old female student that presented to an outside ophthalmologist only with 5 months of blurred vision, nothing really else. They picked up a left-sided visual field defect, blurriness, and some progressive headaches. She had no past medical history of any relevance. She only took non-steroidals over the counter. But on exam, we found bilateral papillary edema and a hemianopia with no other deficits. So this is how the patient was referred to us. And this was the outside hospital scan, where you can see on pre-surgical MRI scan a profound tumor originating right side occipital lobe, then growing into the sinus in the midline and extending into the transverse sinus on the left line, reaching all the way up to the jugular bulb. And that's a formidable challenge, I can tell you. The best thing about these tumors is that they are so rare, because you really are challenged to your best of abilities. I got pre-surgical studies, including CT and CTA and CTVs. And as you can see, the tumor itself was not very hypervascular, but on the second panel, left upper corner, we saw interesting tentorial collaterals that had formed on the side of the occluded sinus. And the CTV below shows you that the sinus was essentially still patent, which creates a huge problem because the confluence was working and you didn't want to lose it on the way. So my first surgery for this one was debulking the right-sided tumor through a standard craniotomy, which I brought to the midline to see the sinus exposed. And I was able to take the entire extraaxial component of the tumor out, but I left the wall of the sinus standing in the middle. And I said, I'm going to restudy this and observe how fast would this sinus possibly close. So 6 months later, the patient presented with 2 days of intense headaches. And as we restudied her, we noticed that, yeah, there was some re-expansion of tumor, as you can see in the middle panel on the top. But now on the CTV right lower corner, you see that there was actually occlusion of the confluence with the superior sagittal sinus being out and the transverse sinus on one side being out. I got a DSA that showed me that the right-sided transverse sinus was still open and functioning. Everything else on the left side was out. So we took this patient back to surgery, and now I did the whole approach, again opening supratentorial, infratentorial, bilateral, and we were able to resect the entire torculum by placing silk sutures and wet clips above and below. And we followed actually inside the transverse sinus towards the left side up to the jugular bulb, where we reached the tumor plug. And as we received back bleeding, we just put a piece of surgical in there, put a clip over it, and left it as is because it deemed to be irresectable at this point. Intraoperative pathology here showed the tumor was more aggressive than expected, WHO grade 2 with lots of mitoses. So we knew that this would require adjuvant treatment. This is what we did. Post-op 2, we had 3 months of follow-up to just see how the post-surgical bed would settle. In the left upper corner and in the right lower panel, you can see there's essentially no tumor left except the portion sitting in the very corner of the transverse junction to the jugular bulb. But we had to cover the entire surgical field with external beam. We did 60 grays in 30 fractions because it was meant to be atypical aggressive meningioma. And just to give you an idea, the local control rates for grade 2 meningiomas should be as high as 90% at 10 years. So I think leaving a tiny piece of tumor behind here was the right decision to preserve function, because in both surgical cases, the patient was able to go home on post-op day 3 with no deficits. So what have we learned from this talk today? I hope that you see torcular meningiomas are rare because they are less than 1% of skull-based meningiomas. They are highly complicated, and this location requires diligent study of your pre-surgical imaging, especially the veins. And this is not the case to save money on. I think you should use all imaging modalities available. I think you need to plan your surgical approach really well individually. Surgical treatment is the treatment of choice in suitable patients, but I think the primary goal would be preserve sinus patency if it's still patent, and grafting remains controversial. There's a fantastic chapter by Balikam Shekhar in Lee's book by Springer that I would recommend to everyone. I think occluded vessels, including the torcular, can be safely resected, but be careful what the goal of resection is. I think quality of life is what matters most. And remember that margins can be treated with adjuvant radiation and achieve exquisite local control. So thank you very much for joining me, and I'm open for questions.
Rames, you're mute.
Thank you very much. That was a brilliant talk. Professor Kasper, really brilliant in anatomy and practical and surgical tips. And any comments from the panelists or participants?
I have one comment. Actually, I want just to convey a message from our colleague Ibrahim Subeh about the concern of shunting, not for the specific case of falcotentorial, but all the talks about pineal and previously craniopharyngioma, that people in the, especially in underdeveloped or less developed country, they put the shunt as a treatment first line and then they go for the lesion. This is not appropriate practice, and you can always put, if you need an EVD, and before you commit your patients for a full shunting for life. This is a message I think will be stated for the trainees. For the falcotentorial, I agree with concern. Whatever the expertise you have with all publication, especially when it comes to the 3 major venous drainage involvement, to make the repair on the 3, they all entail some even temporary occlusion, and this will affect the outcome of your patients. And especially on that case, the bilateral occipital venous congestion that will lead to a major cortical blindness, which the patient will never
recover from.
With accepted, okay? And that's why we have to understand there is something called adjuvant treatment for some cases that you want beyond that safety. And I agree that patient outcome should be the number one for you. I agree with this completely. Thank you, Ek, for the presentation.
Technical question. Ek, it was excellent summary. How do you plug the straight sinus from anterior? A back bleeding from the straight sinus. I always fight with this, you know.
Yeah. So I personally don't, but when I read through Shekhar's papers, you know, he either uses a small piece of Surgicel that he puts into the lumen, and then at the end of the case, when he has done his grafting or his bypass, he pulls it out. That's the last move he does before he closes the access point. There are ways that you can put in a plastic shunt similar to people that use carotids, but the problem with these shunts is they are low flow, low pressure, so there's a high chance that they actually don't maintain during the case. I read up on this, and people are willing to fully heparinize patients for shunting. I'd find that rather daring in the setting of a large P fossa operation to put the patient on systemic anticoagulation. So what I've done is I pre-surgery put the patient on aspirin, that they have slightly improved rheologic properties. If I put a temporary clip in, hopefully the collaterals are less resistant. But I don't put a plug into the straight sinus. Honestly, I stay away from the deep structures. If it's occluded, I take it, but I would not attempt to reconstruct this. The better I get in surgery, actually, the less daring I am, which is counterintuitive, but I think it pays off for the patient because 50% patency is fantastic in gifted hands. And if someone like Shekhar can make a few of them last forever, that's beautiful. But if one of them goes down, you have a real disaster. And they are so rare that you've only done 10 in the last, 5 years, I'd say. I wouldn't try new things on a case like this. If you have a large series of parasagittal meningiomas where you can practice grafting on the superficial veins, I think you learn a ton, you work out the workflow in your OR, and if your team is up for it, you are much, much better posed than if you haven't done this much. So I just want to caution everyone that I think grafting, yes, is possible in gifted hands, but it's a matter of intense debate, and even exquisite centers do it rarely.
Yeah, I agree. I would also suggest if there is an invasion and a reconstruction has a high risk for the patient, for this is a benign lesion. So we always wait until the sinus is completely closed, and then you can come and make a second surgery. I think there's no need. Even some people say you re-implant bridging veins into the sinus. This is so thin, the veins, and this to suture, it's difficult. So also, I always ask myself, as it would be my wife, would I do this surgery? I said, no, I would not do. I just wait until it's completely occluded.
I have to concur with this because you see, if you give it time, there is always a collateral to build up. But that time you can sacrifice the thrombosed vein.
Yes, and you have to be very careful with these collateral veins. That's why I always make an DSA before to see the dynamic and which direction is the blood draining, so that you be sure that you do not close these collaterals. This can also be a disaster.
Actually, Dr. Broggi has nicely shown in previous talks that maybe the use of ICG to see flow directional veins will help in especially parasagittal meningiomas, but you may also use it in this one to make sure that your surgery maintains flow.
Yeah.
Can I ask you again, when you resect totally occluded sinus, as you say, a lot of the collateral would be really in the tentorial leaves near the occluded sinus. So when you resect the occluded sinus, you shouldn't go wide, otherwise you will compromise a lot of this collateral. The problem we observed in our tentorial series that the intrasinus component has a very low, slow growth rate, and most of the recurrence come from the external component to the sinus, even if the case that you have shown. So I'm not, even when you totally resect what seems to be occluded torcula or sinus, there will be still a potential for recurrence, and maybe adjuvant therapy should be considered as well.
So that's true. That's a matter of debate in atypical meningiomas all over the world, right? Grade 2 meningiomas have a gross total resection success rate. We have done this a lot, but even in patients that had gross total Simpson grade 1 resection, 10% recur at 10 years. And it's not clear, you know, is this more global disease? We just didn't see it under the microscope. Or is it we left a margin that was positive and it wasn't Simpson grade 1? I think in these skull-based meningiomas, the whole Simpson grading doesn't really work because that was meant to be a convexity meningioma with dural sleeve resection, which you don't get in this location. So I agree with you. We should be more conservative and consider adjuvant treatment. In general, I would give adjuvant treatment only at documented progression of the residual. I wouldn't give it, you know, just post-op when I have a clean field. So then you can get your MRI scans every 6 months and you radiate when you see progression of the residual. But in her case, in my last patient, she was young. She clearly had gross disease left at the level of the jugular bulb. I am contemplating sending her to Bill Coldwell to get a bypass for the jugular in case this occludes and she becomes symptomatic. I can't do the lateral portion. I'm not experienced enough in big venous bypass grafts or lateral skull base resections for this degree, but maybe you have other ideas, please let me know.
The other technique we used was endovascular stenting of partially occluded sinuses, especially those who present with severe intracranial hypertension and edema, and then resect around the stent or use adjuvant treatment.
Yeah, I'm not a fan of transvenous stenting in tumor cases. Makes your future surgeries a nightmare. And in addition, you may cause emboli as you place the stent and then the tumor embolus travels. So I stay away from this, but I've heard about it. And I think in select cases, it may be suitable.
Thank you very much. If no further questions, next talk by Professor Jose Landero from Brazil, foramen magnum meningiomas from anatomy to approach. Professor Landero.
Jose, you're muted. You need to unmute yourself.
Okay, thank you.
One thing before you start to say, I just want to say, if you allow me, Ramis, Professor Jose Landero, he is the chair of the skull-based committee from the World Federation for the track record in skull-based surgery and innovation, and we are pleased to have him with us.
Thank you. Let me open here and share screen, no?
Share screen.
Share screen. Thank you. Many thanks to Imad, Professor Vladimir Benes. It's a tremendous pleasure to see all of you in this meeting. That were a fantastic lectures, and I try to talk something about foramen magnum tumors, mainly in meningiomas, how I choose the best approaches according to the position and the some characteristic of the tumor. The foramen magnum comprises a bony channel formed anterior by the lower third of the clivus, anterior arch of the atlas, and odontoid process. Laterally, the jugular tubercle, occipital condyle, and lateral mass of the atlas. And posterior, lower part of the occipital bone and the posterior arch of the atlas and axis. Let me say, sometimes the foramen magnum must be considered the two first intervertebral spaces, C1, C2, and C3. Many things go and come from the foramen magnum. It includes the vertebral arteries, anterior and posterior spinal arteries, meningeal branches, muscular branches from the vertebral artery, lower cranial nerves include from 9 to 12, and the roots of C1 and C2. Among the neurostructures located at the foramen magnum are the cervicomedullary junction, the cerebellar tonsils, inferior vermis, and the fourth ventricle. All of this is surrounded by veins, venous sinus, and jugular bulb. Look at the foramen magnum. As you can see here, you have the interior third of the clivus, interior third of the clivus. As you can see here, the hypoglossal canal, and here we have a porus acústico, and near the foramen jugular, and near here we have a jugular tubercle, and this plane is the superior limit of the foramen magnum. Look here, the radicular, the spinal accessory nerve, here the 12 nerve, and here the lower cranial nerves. Here we have a bulb medullary junction, and as you can, it's always remember the position of the ICA is the first branch of the vertebral artery, and sometimes these arteries can arise extradurally. Here, the horizontal portion of the vertebral artery, so-called the V3, and crossing by the accessory nerve, and in the next picture you can see how to identify the vertebral artery. Look here, you have considering two layers to approach the foramen magnum. The superficial layer, you can see the hiatus minors, the spleniocaptis, more laterally the sternocleidomastoides, and semispinalis, and all of them covered by the trapezium muscle. After cut the trapezium muscles and reflected all the muscle of the superficial layer reflected medially, you can see the triangle of the vertebral artery. But before that, you can see the two venous plexus, superior venous plexus and inferior venous plexus. All these plexus can converge all the emissary condylar vein or from superficial vein from the gallia, and into jugular, sternal-jugular vein to internal jugular vein. It's most important to remember that all the vertebral artery, the V3 portion, is involved by the inferior venous plexus. And if you don't need, please don't try to coagulate the venous plexus. If you bleed in something, you can compress and wait, and try to over the vertebral artery in a out channel in C1 and out groove in C1 without touch the inferior venous plexus. It's important to remember the jugular bulb. The jugular bulb is a more medially part of this approach, and sometimes you need to drilling over the jugular bulb, mainly for some tumors, some extradural tumors, and place it more anteriorly and inferiorly downward from C2. Então, if the tumor go more anteriorly and down to C2, sometimes you need to drilling the bone over the jugular bulb, and sometimes you can drill in order to mobilize better the skeletonize the sigmoid sinus, in order to have more space for removing some upward tumors foramen magnum who grow into the intracranial fossa. You never, when I remove a tumor, as the tumor is more middle, is the tumor has a close contact with the anterior spinal artery. And you must remember, behind the tumor, you have an anterior spinal artery. And then the bulking, slowly, small piece, and try to preserve the capsula and arachnoid sheath in order to never touch the anterior spinal artery. And remember, mainly the foramen magnum is limited laterally by the C0, C1, and C2 joints. And sometimes you need to drill the condyle of the occipital bone, the atlas condyle, and the joint is C2, C1. And I always say, if you need to drilling the C1 and C2, please do it. The more important is to preserve the intracranial structures. You avoid the traction of the brainstem and the cerebellar hemispheres. Look, when you choose the approach for the foramen magnum, you must to know something about the nature of the tumor. Is the tumor meningioma? Is the tumor CHORDOMA? The size of the tumor, sometimes big tumor gives a way to resect them. The position of the tumor in relation to the vertebral artery is one of the more important things. Is the tumor in front of the vertebral artery or behind the vertebral artery? If the tumor is in front of the vertebral artery, in front of the dentate ligament, is the tumor placed so anteriorly or anterolaterally? In posterior, in general or posterolateral, is the tumor growing behind the dentate ligament, and you can see the vertebral artery more easy. In the, at least, but not less, the shape of the foramen magnum. Everybody know if the horizontal diameter is bigger or almost the size of the longitudinal diameter, you have a large foramen magnum. If you have a large foramen magnum, sometimes it's not necessary.
Jose, sorry to disturb you. I think your microphone getting mobile moving. If you make sure the microphone, because the audio is not very well, okay? And everybody else should mute his microphone.
The microphone? What?
You are okay, but I think with some motion it becomes disturbed. Go ahead.
Is okay, I go now?
Yes.
Are you listening?
Yes.
Are you listening? Okay?
Yes, yes.
Yes, okay. And then I talk about the shape of foramen magnum. It's very important if you analyze based on CT windows, the shape of the foramen magnum, because sometimes the horizontal diameter of the foramen magnum is bigger than the longitudinal diameter. And then we have a bigger or a larger foramen magnum, large enough to remove some anterior tumors without delaying so much diet. Look here. This is longitudinal diameter and horizontal diameter. Look, is the larger foramen magnum, and sometimes the tumor places so ventrally you can avoid drilling the condyle. You know, it's important to study foramen magnum, the shape of the foramen magnum. The classification proposed by George Blue shows the story of the foramen tumor. The foramen tumor is intratumorally placed posterior or laterally. Posterolateral can be lateral and anterior. Tumors placed laterally can be laterally or posterolaterally. It's so important because most of the tumor placed posterolaterally can be removed to the traditional midline approach, and the tumor placed anterolaterally, even intradurally or extradurally, can be necessary the traditional far lateral approach with a transcondylar or not. And the relation of to the vertebral artery is very important because the tumor below the vertebral artery is this traditional so-called spinal cranial tumor. It's much more easy, but it's based on the old classification from Cushing. The spinal tumor is much more easy than to remove the spinal tumor. Cranial tumor is a tumor placed above the vertebral artery, which means the tumor is coming from the foramen magnum to the intracranial fossa. And sometimes the tumor is placed between both vertebral artery. Is more anterior, is a tumor a little bit more difficult to remove than tumor lateral. The traditional approach to the traditional so-called lateral approach is a lateral extension of
Jose. Unfortunately, the sound is not coming along very well. I don't know, your microphone is nearby or far. You have any mobile next to you? If you can turn it off. The digital of the audio, many they are complaining they are not hearing it very well. So perhaps see the microphone is on the computer or it's attached to your body.
Select the speaker. That's okay?
Yes.
That's okay?
Think, yes, okay. I think moving the body or something in front of the microphone, it changed the audio. So make sure there is no motion around it. Thank you.
And now is okay?
Perfect, yes.
Perfect, thank you. And then I talk a posterior lateral approach. Lateral approach is a lateral extension of the suboccipital craniotomy. I start the incision little bit below the mastoid process and go upward and close to the transverse sinus and go to the midline and downward to the spinal process C1, C2, or C3, depending of the size of the tumor, the extension, inferior extension of the tumor. And generally, the suboccipital lateral craniotomy involved some part of the midline with the C1 hemilaminectomy is enough to reach the dissection of the extradural portions of the vertebral artery and enough to reach tumor placed anteriorly or anterolaterally. And the big advantage, no retraction and vertebral artery. And then the mainstay of the posterolateral approach is to allow the strictly control of the vertebral artery, meaning V3 and V2, and you have a good vision, a good feel about the C1 and C2 joints, and if you need to drill occipital condyle, the atlas and ax, you can do it, and you can, if necessary. Although in many times I don't agree, mobilization of the vertebral artery for some meningiomas. Sometimes you need mobilization of the vertebral artery in cases of chordoma or extradural tumor who placed more anteriorly. As I talk, sometimes the tumor with the extradural extension sometimes involve the cranial cervical junction and involve the atlanto-occipital joint, sometimes jugular foramen and lower skeletal bone, and this complex lesion like chordomas require a modified approach with the condylar resection, a more lateral dissection include jugular, venous bulb, and the carotid artery. But it is another chapter of the surgery because most of the meningiomas of the foramen magnum intradurally can be approached to the posterolateral approach and so far lateral approach. And far lateral approach means control of the vertebral artery V2 and V3, control of the condyle and control of the occipital junction between C0, C1, and C2. And with the approach, we can able to move lesions with anterior or anterior location to the dentated ligaments. And the big advantage, control of the vertebral artery, access to the anterolateral aspect of the craniocervical junction without any retraction of the brain, cerebellum, and cranial nerves, and allow us to extend the approach to until the cipianga or until the tentorium if you need. Look at posterolateral approach. Posterolateral approach or midline approach. I use this approach to tumor place posteriorly to dentate ligaments and tumor place on the midline. Look, it's the large meningioma. The large meningioma giving us a way to remove to strictly posterior midline approach. Look at the patient. If the patient is ready for surgery, you can mobilize it slowly and smoothly and put the patient, protect it, use pads for avoid injuries for joints and muscles, and don't flex the head so much because the jugular venous outflow, and you put the microscope in this situation. I use it to put the microscope in front of the patient. It's more easy to me, but sometimes when I use the so-called far lateral approach to the park position, I use to stay more lateral to the patient. Look at this position, and after totally remove of the tumor without any neurological deficits and reconstruction of the posterior fossa with the same bone. And now we have two pictures and show how you can go with far lateral approach. Or I move all the posterior board of the foramen magnum until you find the condyle, or sometimes you can advance the condyle below the jugular tubercle and drill something in order to open more the anterior, to give more space to the anterior tumor, mainly to have a control of the vertebral artery more anterior and the lower cranial nerve, mainly the hypoglossal nerve and hypoglossal canal. And this is my series. It's many kinds of tumors. And here we have something about the muscular layers. Look, after small coffee was left after incision of the superficial layer, after the superficial layer. As you can see here, you have a external occipital reflected laterally, is the part of the hiatus minor, is a part of the superior orbital muscle, inferior orbital muscle. After remove and dissect the plane of muscle to medially, you can see the so-called vertebral triangle. But it's most important, before the vertebral artery, you can find this artery, the occipital artery is so important, the artery, and then sometimes you can preserve good part of the artery, but it is sometimes used for some bypass the posterior fossa or bypass to intercerebral posterior occipital lobe, but it's not important for me now. Look, the artery is displaced more anteriorly, and this position of the inferior orbital muscle, and here we have the muscular branch of the vertebral artery. We have the branch of the vertebral artery and the venous plexus, C2 racing, and C2 is in close relation. The posterior branch of C2 is in close relation with the V2 between C1 and C2 is the vertical position of the artery before the artery enter in the transverse foramen of C1 and then turn medially in an all groove in C1 arch until to place a little bit to make a piercing and dura in close relation with the occipital condyle. Look at this. And then this portion of the artery.
Dr. Landero, the slides are not advancing, we think.
Oh, okay. Sorry, bye. Is okay now?
We are still on the same slide.
This is it's not advanced the slide?
No, it's the same. We are still looking at the same slide.
Oh, still, oh. Would you like to see here or here? Look here, I show the C1 channel with the vertebral artery entering the groove and C1. And here is the ganglion of C2, and C2 give a branch who crossing the vertebral artery between C2 and C1.
Landero, look, your slide is not moving. You have to exit and re-enter because it's frozen on that slide, posterior lateral approach. You are still on that slide. If you want, get it out and put it?
Here?
Exit the
Here?
presentation and re-put it.
I think the best way would be unshare the screen and then share it again.
Yeah, unshare and
New share?
unshare.
Or unshare? Here again?
You did not exit and come back.
Stop share. Stop share.
And now check sharing, back on sharing the screen and advance it to the slide you want us to see.
Here? Is okay?
Yes.
Yes, you are on the lateral approach at the foramina magnum.
It's completely freezing. I can't. Completely freezing that. I try to. I stop share again. Share screen now.
Imad, maybe I can recommend we try to give Jose a chance to represent this set tomorrow in the setting. We could.
Oh, sure.
We have 9 presentations tomorrow, or spine.
I'll try to start again this.
Landero, try to stop your video. Maybe you have internet issues and stop the video, use only sound.
Sure. Stop the video. I will.
He's going to connect again.
I do not see Landero on the screen anymore.
Jose, are you with us?
No, he left. He's probably trying to connect again. Pablo, you are the host. Are you seeing him trying to connect again? I will try to call him on the telephone.
He is there. He is there. Igor.
He's back. He's back. Yeah.
He's back.
Yeah.
Jose, unmute yourself. Unmute.
Paolo, can you unmute him?
Yes.
Very good.
Sorry, bye. Sorry.
Don't worry. We are hearing you.
You are hearing me?
Yes. If you can put share the screen now.
Yeah, you can give me.
Yeah,
Pablo, can we give the screen for?
Yeah, he should be able to.
Please, you can share now your screen.
Can you give me again, Pablo?
We are seeing the room now. Put your screen.
Do you have any message when you try to share your screen, Jose?
Yes, I saw a small. Animais, join a meeting, but stop here. I don't know. This is the computer is new. It's a very nice computer. Never happened with me this. I'm so sorry.
Do you see the icon share screen, the green one? Jose?
He is not with us now.
Is okay, Pablo?
Yes, now we can hear you, we can see you, but we cannot see your screen. Do you have the green button in the down line? Green button, which?
Share screen.
Share screen?
Yes.
So it's there, the button is there, Jose? Share screen?
Screen? Here is a green button.
You click on it?
Click on it.
I clicked that.
And what does it say?
Okay. Share screen again. Share screen.
Yes.
Here is the lecture that.
I think the problem is that maybe are you in the hospital, Jose?
Yes.
Sometimes also these nets are very good as they are overcharged at sometimes. We might have some problems because you are sharing your audio.
Oh, we just saw it.
Yes, but this is what some time ago probably. Let's see. Can you move your mouse to see if it's online now?
Yes, sure.
Okay, you have the presentation.
Did you see the slides?
Yeah,
Did you see the slides?
Yeah, perfect.
Did you see the slides here?
Yeah, we are seeing the
posterolateral approach. That's okay here?
Posterolateral approach. Go ahead.
Yes. This let me. And as you can see here, the tumor is placed behind the dentate ligament, and the tumor invaded the posterior cranial fossa. The patient present with a the nerves. Most of the times, the symptoms of the patient are radiation to become a very rare even in Korea. And then the patient has a radiation and you don't have about the thumb one time. And the tumor is placed posteriorly, laterally, and then we put the patient in prone position, avoid flex so much the neck because the venous patterns of the jugular vein, padding all the patient avoid the mechanical injuries. And as you can see, the tumor and the postoperative view, the tumor were completely resected, reconstruction of the posterior fossa with the same bone removed during the craniotomy. But when the tumor is placed anteriorly or anterolaterally, you need to open more laterally the tumor, the craniotomy, the so-called craniotomy, remove one part of the suboccipital fossa and all the posterior board of the occipital bone until the condyle for place more anterolaterally. And for tumor place anteriorly, so anteriorly between the two vertebral arteries, sometimes you need to go to drill some part of the occipital condyle as we schedule here. Is my series. We have a little bit more but I have to the endoscopic approach. After place the patient, I used to cut the superficial layer composed by trapeziums, sternocleidomastoideus, and semispinalis. And after splenic two, I consider two layers, and then I cut the layer and left it for restore this muscle after the craniotomy. Remember, the more lateral place the occipital after the second layer, and then you must be careful to cut the muscle and the second and reflect the muscle more medially because you can have a hook of this artery and bleeding a lot. Sometimes is very difficult to control, and sometimes I think it's very important to preserve all the atomic structures until you found the region. Look at the after the so-called muscles from the vertebral triangle in general insert on the transverse process of the tumor is dissected from the midline and from the occipital line to more laterally in order to have a control of view and view 1 since the from C2 from C1 until they are more horizontal and enter in the outgrowth and C1 until make a piercing of the dura or go to find the other branch and become a basilar artery. Look at the artery. After piercing, the artery is crossing by the spinal accessory nerve and mainly posterior branches from the C1 and C2 crossing the vertebral. During surgery, you must preserve this branch. But sometimes you need to cut together the dentate ligament. Look, never forget this branch of the artery. The vertebral artery gave some meningeal branch, posterior meningeal branch, and the muscular branch. This branch of the artery, when you dissect the artery from the groove of C1, you can find the artery, this branch, and you need to coagulate before to cutting or inadvertently rupture this artery. I use it to open little bit more laterally and go parallel to the sigmoid sinus in order to avoid on the midline. Sometimes I need to do incision, but most of the times I use the straight incision, go parallel to the sigmoid sinus and open until is necessary. You can go until the temporal and open all the posterior fossa from one side and remove the tumor row going to the triangle or the territory. Look, about the position of the patient, when I do a forlateral, I use the so-called department position. After the patient is ready, I little bit move the red. I put one eye, look to the top, and another eye look at the wall. Look at the wall. Okay, it never turns excessively the head because you can disposition the vertebral artery and the second of vertebral artery can be a little bit more difficult. And another big risk when you turn excessively the neck is to have a dissection of the artery because after spinal surgery. And all this after prepare and open the superficial layer, deep triangle, dissect the vertebral artery, open the tumor. The inferior limit of tumor is the inferior limit of tumor, and you can move all the tumor. And most of the time, you always see the image, the cerebellum and the brainstem displaced to the other side. And the surgical techniques, I try the first after incision of the muscle, I flex the muscle medially and laterally. Remember, I use to reflect the muscles. I use to reflect the muscle from the vertebral triangle, mainly superior oblique muscle and inferior oblique muscle. I reflect it laterally in order to see the vertebral artery and between the C2 and C1 and over the whole channel in C1. The technique for removing tumor is always the same. The section of the tumor, piecemeal dissection, and always look when you have a tumor placed more anterior with the final stage of the section of the tumor with the anterior spinal line. I'd like to talk about how much to look at this condyle. Is the condyle I have here in this area the vertebral artery, and I need to have more control of the vertebral artery. And you can see a lot of bone here. If you need, you don't need to avoid oversizing the bone daily. But if you need to dissect the vertebral artery, you need to have more control of the internal structure. Please do it. Drill the bone, and after surgery, you can see if necessary to do some maneuver, put a soft collar or even posterior arthrodesis if you drill a lot. Remember, for foramen meningioma, I never needed to do a stabilization after the surgery. Look at the tumor more anteriorly, is big tumor, and this tumor is removed through the traditional far lateral approach without any neurological deficit. Look at the tumor, give a way to remove to the far lateral approach with the removal of the M lamina of C1, partially C2, and that's enough. Look at the all is the same. All the same. Look at the patient in position. I started the incision down to the mastoid process, go upward and straight line, cross until the midline, and descend and go downward to C2 or C3. After second, the muscular layers, I did the craniotomy, and I do a craniotomy according the intercranial stage tumor. Sometimes I need to expose the cranial medullary junction and part of the cerebellar hemisphere and part of the midline. As you can see here, the cerebellar hemisphere, the brainstem, and the accessory nerve, the space after remove the tumor, and I can reconstruction the craniotomy with the bone removed before approach this tumor. Look at this. It's always the same position. The patient is fixed in Mayfield, in park bench position, and the patient little bit rotate. We padding all the structures like a brachial plexus. The shoulder is secure and go backwards and fix it, or the patient fix it, because sometimes we need to mobilize the patient more medially or more laterally. And you can see the big tumor, the patient has only radiation. And as you can see here, the image is all the same. Look, after the far lateral approach, we don't need to drill nothing. No contact drill. Look at this. Cerebellum, the tumor is here, is the amygdala, and here's the brainstem, and look at the 11th nerve crossing the tumor until find the radiculars branches from the C1 and C2. Look here again, open the arachnoid and remove the tumor with safely, without any injury of the lower cranial. And you can see here the vertebral artery. You must be alert, because the tumor go upwards, go until the sepiangle. And then we dissect the tumor from the lower cranial nerve. And then the patient must be alert, some complication after the surgery. And I cited the tracheostomy and sometimes the enteral food until the patient recover the function of the lower cranial nerve. What's happened with the patient? Look at this. Here, the tumor were totally removed. Look, the condyle is entirely normal. The C1 condyle and C2 show perfectly. Is small craniotomy, and C1, part of C1 was preserved too, and the patient immediate postoperative period need a tracheostomy and need the enteral food, parenteral food, and the patient after 2 months, 2 months after the surgery, recovered completely well without any neurological deficit and without any residual tumor. I so call it a totally remove this tumor. Look at the tumor is more laterally tumor. I use the same approach. Is the incision is completely different, but look, I always include the mastoid process and until C2 and move the patient, prepare the fascia lata if it's necessary, but it's very rare, and immediate postoperative view without a total removal of this tumor. And look at this tumor. That is the tumor is anterolateral tumor. As you can see, the dura insertion anterior to the bulbomedullary junction. the vertebral artery is displaced, the patient has some motor deficit in the four members. As you can see here, the same approach, the cerebellum, brainstem distorted to the other side, the big tumors, the radicular branch from C2, posterior to tumors. As you can see here, the tumors and C1 branches, and probably is the 11th nerve here, brainstem, and then open the arachnoid and establish the limit, cranial limit and caudal limit of the tumor. This is here, the last nerve is here, pica, the vertebral artery crossing by branch from posterior branch to from C1, and look at the vertebral artery, and you can see, and then in this part, I started the bulk of the tumor, until find the dura. Look at the vertebral artery without any mobilization. I left the vertebral artery in the position. Here is the posterior branch, and here you can see the C1, and probably here is branch from the hypoglossal nerve. And then look at this, it's a big screen. Look at the vertebral artery, pica branch. Look here, and you can see here the hypoglossal branch of the artery. Hypoglossal branch, 12th nerve, 11th nerve, branch from posterior branch from C1 and pica, and the vertebral artery is here. And the brainstem totally freed from the tumor, and the patient in the postoperative view is a precaution. I put the enteral foods before test the patient, test all the cranial nerves, and then if it is okay, I remove the enteral, I remove the tube, and the patient in the late postoperative view without any neurological problem. As you can see here, the postoperative control, the tumor were totally removed, that, and radical removal of the condyle, and I use it only to the extradural tumor, mainly to skull base and upper cervical spine, tumor cream like a chordomas. Very rare to remove it, to need to remove a condyle, occipital condyle to meningioma of the foramen magnum. And here we have a young girl, and the tumor placed between the two vertebral arteries, totally ventral tumor. The patient had a small depth of the 12th nerve, and then look at the patient. It's the same position. Look at the process, midline process, and then I expose all this area of the tumor. It's actually the MIR and CT with the three-dimensional and bone windows is essential for the tumor. That are indicated to this kind of patient. Sometimes I use a venous MIR in order to identify the patterns of the sinus, and sometimes in midline tumor I can approach the best approach according to the patterns of the sinus. The patient in position, the head is a little bit turning, and one eye to the floor, one eye to the wall. The patient is fixed, the shoulder is secure, and the postoperative preoperative view, I need to mobilize it a little bit more, the vertebral artery, because sometimes the sinus, in some case, like this case, and the immediate postoperative view, branches from C1, the vertebral artery is here, and the tumor removed from anterior point. And as you can see, the postoperative view without any neurological problem before and after surgery.
Jose, you have 2 minutes left. Jose, you have 2 minutes left. 2 minutes left.
Oh, sure. Sure. The tumor, I associate a far lateral approach with the extended petoso. The far lateral can be used with extended petoso. I remove totally the tumor and make a facial graft 2 months later. And the patient recovered very well. And at least the video about this tumor is the tumor, is the patient with a small anterolateral tumor, and I could to remove all the tumor. Look, open the dura, flat the dura, is the dura, as you can see here, the vertebral artery, as you can see here, the spinal axis nerve, and here we have some branch from posterior raising. I debulk the tumor and remove all the tumor, as you can see in the postoperative control. Look here, it's the vertebral artery here and the 11th nerve. This is my series. Most of the tumor were totally removed. I have one a meningioma, is another kind of big meningioma, and the tumor I injected fluorescein, dissected the vertebral artery, as you can see here, and I could remove all the tumor and delay in the postoperative field. Complication and mortality: 6 patients required gastroscopy and tracheostomy, 12 nerve palsy cases, 1 transplant, 7 nerve patients, 1 required anastomosis, 4 cases, 2 required the operation. I'd like to talk about foramen magnum CLIVAL tumor. My last case is the small tumor placed anteriorly over the C2, and over the endoscopic process, and I can move the tumor to the endoscopic approach. As you can see here, the vertebral artery without touching any nerves. It's a big advantage of the tumor. You cannot displace the brain structures. You cannot touch some nerve, but the tumor must stay strictly on the midline. If the tumor is spread to the lateral side, it's very difficult because you don't have space for visualizing the 6th nerve, the 12th nerve, but this tumor is possible to see. Look, the 12 and all the lower cranial nerves. And the postoperative view, the tumor were totally removed. Is the tumor, I decompressed the tumor because the tumor were operating the entrance, and I did a petoso approach and remove one side of the tumor and the another side I am waiting now. And CHORDOMA is not necessary. And I'd like to have this message. Yes, with the approach. Never spend some time with the approach. Remove a tumor. Posterolateral approach is feasible for most of the foramen magnum tumor placed ventrally or underlaterally. Vertebral artery can be exposed, but be careful with the transposition. Most of the time is necessary. And considering endoscopic laser approach for midline meningiomas and lower clivals and above the odontoid bag. I'd like to say thank you for your cooperation with my problem with the internet. Sometimes the thing doesn't depend of us, and thank you for all of you.
Thank you, Jose Landero, for your presentation. Unfortunately, audio was not perfect, and the only things I can promise that we will take your presentation in one of our future webinars talking about skull base and give you the chance again to give it, because I saw nice videos and good cases. Unfortunately, the video, they could not be followed by the attendee or by ourselves. So I think it has no sense to give any questions at this moment. We are over time. I'd like to thank the panelists, and I'd like to thank the speakers and the attendees to have been patient with us about this audio is not from the host. And tomorrow we will have another exciting day. Will be chaired by Professor Benish on spine and spinal cord. And I hope that everyone will attend it. There will be a great presentation. I leave the venue for Professor Benish to say a few words for tomorrow program. Vladimir?
Yeah, thank you, Imad. I have nothing much to say. I just would like to invite you for tomorrow program, since it will be spine, which we never ever had. So it will be our premiere, and I believe that we shall be good, because Imad has invited really good lecturers. So be here at 2 p.m. Central European, which is Imad?
12 Greenwich Mean Time.
Greenwich Mean Time, it's noon, I guess.
Yeah, 12 o'clock.
Well, looking forward to see you tomorrow, and have a nice day. Bye-bye.
Bye. Thanks,
Bye-bye.
Pablo. Thanks,
everybody.
And thanks to all the panelists, Henry, everybody.
Henry,
The panelists, Igor and Andreas for moderating the session.
Brother, hi Pablo.
Thank you.
Nice.
Yes.
Hope to see you
tomorrow,
here.
everyone.
Tomorrow.
You.
Bye-bye.
Thank you.
Auf Wiedersehen. Masalama.
Auf Wiedersehen.
Auf Wiedersehen.
Mach's gut.
Ja, ihr auch.
Auf Wiedersehen.
Wiedersehen.
後藤先生、お疲れ様でした。